Good afternoon, everyone, and welcome to the Health and Government Operations Committee. I am your chairman, Jocelyn Peña-Melnick, joined by my vice chair, Bonnie Collison, to my left. I'm going to go through some of the rules in the committee respectfully. Welcome, everyone. It's great to have you. I am going to go to some of the rules. The first one is, please set your electronic devices to vibrate. I'm going to do that too, because sometimes I'm embarrassed. I forget. So there you go. Practice what you preach. I know yesterday I did that. You need to remind me. As a reminder, there's no food or drink allowed in the gallery. And the reason is because then staff has to clean it and they have a lot of work. Now you're going to see that we do drink, but that's because we need to keep hydrated because we're here 5-6 hours. And then if we get dehydrated, there's no one tomorrow to run these bill hearings, okay? Now, for each bill in this committee, I made the decision not to time the bill sponsor. However, please don't abuse it because then you're going to have to make me interrupt you, and I don't want to do that. Okay? So be reasonable. The rest of the witnesses, basically, you get 2 minutes. A timer is displayed on the screen, and a sound will play when your time has expired. If the witnesses have 2 minutes, right? And if you actually have, if we have, let's say 10 favorable, 2 unfavorable, I try to take maybe 3 or 4 favorable and then do the unfavorable just to be balanced, right? Because that's the fair thing to do. To our wonderful committee, you ask amazing questions. Thank you so much for adhering to sometimes our usual committee rules. And those of you that have to pay dinner, right? If we end up here very late, you have to pay for dinner. But adhere to the one rule, one question, and one answer. And please keep your question brief and direct your question to the one person on the panel. Members of the public, you're able to watch these proceedings live stream on the Maryland General Assembly website and on the YouTube channel. So I'm going to give you the bill order. However, I have a little caveat that sometimes I need to change it if the bill sponsor is not here or we're waiting for some witnesses. You'll see that we get up. It's because some of us have bill hearings in other committee. It's not out of disrespect. These proceedings are recorded, so we watch them, but also we have this beautiful reading that we read before we come here and during, so, we give it a lot of attention. This is actually the bill hearing order. We're going to start with House Bill 1103. Delegate Wallach, will you be so kind and come out with your panel while I call the rest of them? House Bill 874, House Bill 1289, House Bill 1120, House Bill 939, House Bill 938, House Bill 953, House Bill 1085, House Bill 1074, and the last bill of the day is House Bill 932. So, Delegate Wallach, will you please come up with Carmel? Who are your Arthur Flax, I think? Hold on a minute. Who's on your panel? Oh, they're right there. Yeah. Go ahead. It will help if I look up from my sheet. Anyway, yeah. And welcome to our committee. This is your first time here.
That's right.
They're going to be very gentle. You may get started. Good afternoon.
Good afternoon. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. For the record, I am Delegate Sarah Wallach, here to present HB 1103. This bill establishes a 3-year pilot of the Miriam Kelty Aging and Senior Social Connection Hub and Spoke pilot program, quite a mouthful, within the Department of Aging, and requests a small amount of funds to support the pilot. Aging, as you know, needs follow a spectrum. On the one hand, you have individuals who need full-time care 24 hours a day, 7 days a week. And on the other hand, you have folks who are fully capable of living independently on their own. But many seniors don't fall into either one of those two categories. They need a little bit of support, but not full-time care to be able to age in their homes. So a little bit of help. And that's where the villages come into play. The village movement is a grassroots and volunteer-led effort that allows seniors to stay in their communities as they age. Their goal is twofold. First, it is to provide seniors with services, and second, it is to help them stay socially connected. So for example, volunteers help their senior neighbors by driving them to the doctors or bringing them to the grocery store, by mowing their lawn or shoveling their driveway when they need it. This is especially critical for seniors who are not living close by to family and relying on others for support. And that service time that people are very willingly giving to take care of their community members, if quantified in dollars, would be tremendous. So our counties and our state are saving significant amount of money through this village movement. Secondly, villages address loneliness that our country is struggling with and can be felt especially acutely by seniors. Villages host numerous social events which help seniors feel socially connected. Feeling that you belong matters at every age, and villages provide a sense of belonging and community for all who are part of them. A challenge that has come up for villages is managing the inevitable administrative tasks, such as fundraising, managing finances, etc. Volunteers are often unable or unwilling to take on that work because they frankly want to be helping their seniors. And to address that, 7 villages have come together to form a consortium, a hub and spoke model. This model will centralize administrative tasks so that individual villages within the consortium are freed up to do their core work, the service and the social connection work I just spoke to. It's the first time that this has been tried at this scale in our state. Moreover, villages are springing up throughout our state, and they're reaching out to guidance for more experienced villages that are part of this pilot. But these villages are finding it difficult to consult emerging villages because they themselves have these tasks to take care of. So the goal is that by pulling these administrative tasks into a hub and then having villages in the spoke, that they will be able to be sustainable, meet the needs of their community members, and potentially also serve as mentors for others. So to wrap up, after this 3-year pilot, our state will get a report from this consortium about lessons learned that can be leveraged statewide, and this will be an investment which will yield very positive returns. Governor Westmore has spoken eloquently and often about service, and villages are a shining example of that in our state. Thank you, and I urge a favorable report of 1103.
Thank you very much, Delegate, for your testimony. Who will be next? How are you?
Good afternoon. I'm fine, and I'm so pleased to be able to be here before your committee. I'm Carmel Roque. I'm Secretary of Aging. I thank Chair Pena Melnick and Vice Chair Collison for the opportunity to testify in favor of House Bill 1103. And I thank my colleague and new friend, Delegate Sarah Wolick, for her leadership in bringing this concept forward and working so collaboratively in partnership with the Department on Aging. I know all of you know that Marylanders are living longer lives and that we are in the midst of a demographic phenomenon that will make these kinds of pilot projects so important as we begin to test new models for better serving the older population as it continues to grow in Maryland. And also in response to this demographic shift, MDOA was actually recently had an executive order signed by the governor where we were mandated to prepare Maryland for longevity. The village model is an outstanding volunteer-driven, low-cost, high-value way to support older adults living in their own homes. Some of them charge a membership fee, but many do not, and this is solely on a volunteer basis. The village model in this pilot aligns perfectly with our state's longevity readiness initiative. The idea is to support social connection, reduce loneliness, and deliver much needed services to older Marylanders. This pilot program, which will be produced by a nonprofit consortium, aligns with our role planning for longevity readiness.
You can go ahead and.
Thank you. So MDOA's role, Maryland Department on Aging's role, is in convening and spreading successful interventions and best practices that will benefit older adults in our longevity ecosystem. This bill provides a clear, workable outline for Maryland Department on Aging and the Village Consortium to do just that. For these reasons, I urge a favorable report on Bill 1103. Thank you.
I want to take a minute to say thank you for working with me and the committee in the interim, for making yourself available and your staff as well. And the committee really appreciates it. I don't think people realize that not everything has to be resolved with a bill, right? You can get a lot done by working with the department, and we encourage that. So thank you. Next, please.
Hello, I'm Constance Rao, President of the Montgomery County Villages Consortium. And I'm here on behalf of the 7 initial members who represent villages from all areas of Montgomery County, north to south, and established villages, ones needing assistance at this point and ones in development. The Administrative Services Organization approach, which is the consortium approach being developed here, has worked in village and association management models across the country because it spreads necessary infrastructure costs across a wider base of organizations, thereby reducing or, if subsidized, eliminating costs. While our model will copy some of the ideas of organizations already in existence across the country, it will also have unique elements given the history of villages, our geography, available services, and other factors. Thus, the study approach is a good one, for no doubt we will have data to share and stories to tell. The dearth of villages in other parts of the state means that the findings can be used when the study is complete. We commend Delegate Wallach for introducing this bill and hope that it finds support. Thank you.
Look at that time. That was amazing. You have 48 seconds left, but you cannot give it to the next. Go ahead, ma'am.
Yes, good afternoon,
Good afternoon.
and thank you for the opportunity to testify. My name is Elizabeth Carrier, and I serve on the Montgomery County Commission on Aging, and I'm a founder of a village in Bethesda. The commission has strong support for Delegate Wallach's bill and has submitted a letter of support. The commission believes that villages are vital contributors to the well-being of older adults and can help them thrive in their communities. Testing and providing additional administrative support in a hub and spoke model as described in HB 1103 will be a vital way to expand the village movement and help older adults age in place. To date, the 30 villages in Montgomery County have achieved outstanding results and have a shared goal to reduce social isolation and provide volunteer help to seniors aging in place. However, villages in diverse and lower income communities need startup to support to achieve similar results. HB 1103 will provide needed administrative support through a hub and spoke program that provides administrative services to villages. This program will assist in the growth of villages in diverse and lower income communities and will help to ensure the sustainability and efficiency of existing villages. The proposed pilot will centralize tasks so that member villages can share their expertise and maintain and increase services and events that are offered. The pilot can make an important contribution to learning, testing, and developing best practices for this model of village management. The innovative model can offer insights across Maryland and help the Department of Aging with their mission to make Maryland longevity ready. We appreciate Delegate Wallach's work for introducing this important bill. Thank you.
Thank you so much. I appreciate it. You did well too. I'm going to now open it up for questions, and this is the delegate first time here, so we say we will be gentle with no questions, right? So the real questions now, are there any questions for the delegate? Delegate Robin Lewis, Delegate Johnson afterwards. You're welcome.
For this really interesting and inspiring bill, and thank you to your panelists. I'm curious as to, this is perhaps it's my fault that I wasn't aware of this villages model and the initiatives around the state. It's inspiring. How would a community go about starting up a village if they wanted to do that now? And would the process change with your bill? Whoever's best to answer.
I can certainly say that. As it stands now, in order to develop a village, you need leadership. You need a group of people who are willing to work through the issues that are necessary to establish a nonprofit organization that provides a certain range of services. And you need a group that also will recruit volunteers. And you need to have a way of finding out what it is the community needs. You need to have an assessment vehicle. The problem now is that if you don't have all those things in your community, and there are areas of Montgomery County that do not now, you simply don't have the grist for the mill that is necessary. And that's the problem. When we get the consortium going, we are going to have at least a part-time, we have one approved at this point, outreach worker who will be able to go in and work with leadership if the leadership is there through the established process for doing this. It's not that there isn't a manual, there is a manual. It's just that you have to have people who are willing to go through the steps. And the problem with it is that as I think Delegate Wallet pointed out, most people who are interested in starting villages are interested in helping their neighbors. They are not interested in establishing a nonprofit organization. They aren't interested in any of that administrivia or money or any of that stuff at all. So it has to, you have to be able to get those resources together. We are hoping to be able to help the startups in areas where they may not be able to get volunteers once we're up and running.
You're welcome, Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing the bill and your panel. I'm with Delegate Lewis. I haven't had a lot of exposure with villages. So what is the goal of the village? You've talked about resources, and can you explain to us what this hub and spoke model, what that is and what that does?
Okay, so let me start with what villages are and what they do. So let me start, I'll just very quickly give a thumbnail from Friendship Heights Neighbors Network, which is, for any of you who know, is on the border between the district and Maryland. So we have seniors who range from age 65 to 102. And we have a group of seniors who start out usually as social members who have no needs for help. They are mobile, they are able to participate in things, but they may be new to our neighborhood or whatever, and all they really want is social connections and maybe attendance at programs that would not be offered by other sources. But by the time we get to people, especially in their 80s and their 90s and 100, they've fallen, they have disabilities, the mobility is limited, they need rides, they need people who will do their shopping for them, they may have eye issues, whatever, they need people to read to them. All that stuff begins to emerge. So what the villages are set up to do is to provide programs for people who just want social connections so they can connect with each other and get to know each other. Usually also we have lunches and coffees and things like that, and affinity groups, meditation and other things where people can get together and get to know each other. But we also provide the basic core services like rides that requires criminal background checks for volunteers to provide the rides and all that other stuff that provide the core services that volunteers, non-medical volunteers can provide for the people. Okay. Now that's fine. That's villages. And there are 30 of them in Montgomery County. Just imagine they're typically neighborhood based. That means very small. They may have, 50 members. The largest ones at this point have about 200 members, okay? And if they charge, you can imagine, if they charge dues, how small the pot of money is. When the volunteers that start the villages run out of steam, which typically is 3 to 5 years after the beginning of a village, there's no carry on after that because they don't have enough money to hire staff to replace the volunteer labor that used to run things, okay? But on the other hand, they want to keep going for their neighbors. That's the sustainability issue. Then the other issue, which is how do you get villages started in areas of the county where there are none? Typically, the areas are low income and or rural in Montgomery County. And getting them started requires having a structure for doing it and a way of reaching out and a way of also funding what's necessary. So that's the village level. Administrative services organizations and the association management field has had this for years and years and years. Centralize the core administrative tasks that have to be performed for running a village. So communications, typically a monthly newsletter, weekly e-blasts about what's going on, how to get in touch with people, what to do, and all of that. Programs. In our model, we're going to have at least one educational and at least one cultural program for every month so that there is a way to get people together for social connections. The operations end. You would be surprised, those of us who didn't grow up with computers, how everything is related to what your website is, what the database is, how you have a computer system that matches drivers with requests for drivers, all that kind of stuff. If the villages don't have that among their own village volunteer level, if they don't have volunteers who love computers and love doing all that stuff, we will provide that service for them. And so it goes. Financial management is another big bugaboo. Unless you have a CPA who loves to do volunteer work, which most villages do not have, you're going to have a piecemeal approach that is not very functional and certainly does not meet nonprofit standards. So we can take care of that. And there are other things, volunteer training and all the rest. Centralizing this for the villages cuts the cost and also makes it possible, if we are successful, in going to potential funders who are in the government, but also in foundations to help us make these services low cost, or if necessary for low income areas, no cost to the villages. And that's how we keep it going. And this is how, that's the hub and spoke. That's the hub and spoke part. And there are hub and spoke models across the country.
All right, thank you. Thank you, Madam Chair.
If I may just add that there are,
So we only allow one person to explain it.
sorry?
But someone can have a follow-up question for you. Does anyone want to have a follow-up question for you, Delegate Olston?
Yes, Delegate Walko, is there anything else you'd like to add?
You know, we gotta abide by the rules, but we are treating you kindly. Go ahead.
I appreciate that question. I was just going to say that there are 43 known villages in our state. Certainly, 75% of them happen to be in Montgomery County, but they are actually present throughout our state. And those are the known ones. There are a lot more informal ones which haven't taken the step to set up that 501c3, but are really wanting to do this work. And so it's a lot, sort of the numbers don't reflect necessarily the grassroots effort that is in play. And the hub and spoke really would centralize this. Into your earlier question as well, Delegate Lewis, you know, if this model goes forward, the lessons learned, because that is sort of what we get back as a state from it. At the end of this pilot, there's a study, there's a report that the hub and spoke model will provide the state, which will explain best practices, how to leverage a consortium, how to bring those administrative tasks together. Potentially, if you have a variety of villages, maybe not all of them need to be a 501c3. Right. Maybe it's just the hub that needs to be that. And the spokes don't need to have to go through all of those administrative tasks. But we don't know that yet until we actually execute this model and test those things out. But hopefully it can be leveraged as a way to expand and formalize a lot of this work.
Okay, great follow-up question. Delegate Gazzoni, followed by Delegate Bandari.
Thank you, Madam Chair.
You're welcome.
So I'm curious if or whether there's some plan to work with other nonprofits in the area. So for example, in Howard County, there's a service called Neighbor Ride, which can do some of these things. And so would part of the process be to sort of build out network in a little bit of that space to use other resources that are already established and just be able to make connections?
The answer is yes. There's a JCC in Montgomery County operates a rides program. Now it's just software and recruiting villages. But it may well be that instead of buying a software program to match, the consortium may in fact contract with JCC for the software and the volunteer services thing. Yeah, we hope to use everything that exists in Montgomery County because we are blessed with numerically great, but very limited resources that only serve certain sectors, and that's the problem.
Thank you.
Delegate Bandari.
Yeah, thank you, Madam Chair, and thank you, Delegate Oleg, for this wonderful bill, and thank you for everyone for advocating for this bill. And it is very impressive report of collective impact report, the contribution of volunteers, volunteer rights, and would you mind sharing some experiences while working? And thank you so much for your commitment in the challenges. Support we passed this bill centralizing administrative tax. Based on your experience, what are other challenges that you feel while being active with this group?
Well, I think we can't minimize the cultural shift that is going to have to take place. Neighborhoods, villages are typically formed at the neighborhood level with people who know each other and go back to days in PTAs and other things. To have them now have to somehow relate to an organization that provides administrative services only, when they don't care anything about administration and management, they really don't even want to hear about it. They just want to take care of each other, is a real cultural shift. So we're going to have to convince people. It's quite, I call them the show me stage. We're going to have to show them that we can do stuff that will help them, I think, before we can attract all the people that we need to attract. The second thing, of course, is funding. The other hub and spoke models across the country in general are not in the shape that we are. They either have a governmental source of funding or they have big businesses or whatever who put money into a pot. The Denver model, that is the one we aspire to, allows people at the village level to pay what they will instead of having to pay dues levels, $300, $400 or whatever a year for funding that is impossible in many areas of the county and many across the state. We simply don't have any of that in Montgomery County now. So getting this going and getting this sustainably funded is going to be the second challenge. The third general challenge is frankly, and I say this with all due respect to everybody and their views, we still have both ageism and anti-volunteerism at very high levels in our culture. And I say this with all due respect, having been part of that other side, or at least allegedly a part of that other side for years, because I'm a retired hospital CEO, and I ran hospitals in this state, and I know how people see things. Unless we can convince people that volunteerism is not just nice if you can have it, but it doesn't do anything. Unless we can convince them that it's a key element to meeting the challenges of taking care of all the old people that we have in this state, we're always going to be pushing that rock up the hill. So I would mention those three things. But we're there, we're strong and getting stronger, and willing to take on the challenges.
Any other questions for this panel? Seeing none, I have no doubt that you will show them.
Thank you.
None whatsoever. Thank you so much for being with us today. We really appreciate you. We do have more witnesses, and if you can come forward when I call your name, please. First, I have Joseph Morrison, Christy Hollins, and then will you be so kind and bring the virtual witness, Mary Jo Deering? And if you can get started as soon as you sit, that will be wonderful. And welcome to the HGO Committee.
Sure. Okay. Well, I hope this isn't redundant after the questions. My name is Christy Hullings, and I'm here representing Strathmore Belpre Village, which is a new village in development that is joined with the consortium. So we're one of the 7 village members. And thank you, Madam Chair, Vice Chair, members of the committee for having us here. It's no news to anybody, but aging isn't easy. Too often, seniors are confronted with loss of strength, mobility, memory, friends and loved ones, sense of purpose, home, and with that, loss of independence and privacy. But a village can help. A village is a ride for someone who can't drive. A village is having a neighbor to call when you need someone to change your smoke detector battery because you're not supposed to climb a ladder. A village is having events to look forward to, such as the Community Volksmarch, or learning techniques to alleviate stress, or learning about a culture and home country from one of your new neighbors. A village is a friendly face that stops by to check on you regularly so you don't feel all alone in the world. A village is a way to give back to others by bringing a meal to a neighbor who just got out of the hospital, or helping a senior open an email PDF attachment and then find where the downloaded file went. A village is a community-created support system that allows seniors to stay in their homes longer and maintain their sense of belonging, purpose, and community. Just as a village pools their resources to support its members, the hub and spokes model of a consortium can also provide that same sense of support to the individual villages. This is why I support this bill. As a representative of a new developing village, the consortium can provide collaboration opportunities with seasoned experts who you just met, who can serve as mentors. Leaders from the other spokes villages can help navigate the ins and outs of each new village spoke so that we don't have to reinvent the wheel. I had more, but I'll stop. Yes, I am in favor of this bill. Thank you.
Okay, great. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Joey Morrison, and I'm not representing any specific group or organization. However, last year I was a part of a group of graduating MBA students that worked with Secretary Woods and the MDVA to look at the cost and quality of care for different models of operating state-owned veteran homes and retirement centers. HB 1103 helps to address really 3 major points that came out of our research. Those would be facility availability, quality of life, and cost. So again, most of this is going to be from the veterans perspective, but so right now the state of Maryland currently does not have anywhere near enough number of beds to handle the existing elderly veteran population, which is, like all other elderly populations, expected to increase steadily over the next several decades. HB 1103 would allow elderly residents to stay in their homes for a longer period of time, reducing the overall demand for these limited care facilities that already exist. And these care facilities have also experienced significant drops in staffing levels over the past few years, making the problem even worse. People also tend to overwhelmingly prefer to age at home instead of moving to an assisted living facility or a skilled nursing facility. The setup that this bill helps to move forward would allow the elderly population to have a greater say in what type of care they need based on their preference instead of necessity. And this would help increase their overall mental and emotional well-being. Our research looked at state-owned VA care facilities across the country, most of which did offer mixed skilled nursing and assisted living facilities. The average care for these facilities was between $88,000 and $112,000 per bed annually. Now, most of the elderly population that this bill would help support, they would need something more along the lines of assisted living, which is significantly cheaper. But this, allowing the residents to stay at home and using the type of support that this bill helps build, helps significantly reduce the cost to that population and the state.
Okay, thank you very much. Next, please. Mary Jo Duran, will you be so kind to give us your testimony?
Thank you very much. Yes, I'm Mary Jo, and I'm the president of the Washington Area Villages Exchange, or WAVE. WAVE is the nonprofit umbrella organization that brings together 79 nonprofit villages in Maryland, Virginia, West Virginia, and Washington, D.C. We offer programs and services to help them learn and grow. We serve the 43 known villages in Maryland. In the nearly 15 years that we've been serving villages, we've seen significant evolution of approaches to creating and sustaining them. The original model of the geographically small neighborhood-based village still flourishes, but in addition, the value of collaboration and economies of scale has promoted new models capable of assembling more resources for aging populations. We're also seeing more multi-generational villages. What remains the same is the neighbors getting to know and help neighbors principle. The hub and spokes model is being explored around the country as a promising approach to help sustain existing neighborhood villages and make it possible for new villages to be created in underserved areas. By gathering certain common administrative functions in the hub, spokes villages can focus on the hyper-local neighborhood connections. The proposed pilot project can make an important contribution to the learning, testing, and developing of best practices for this model. There's a dearth of evidence about this innovative model, which seems potentially to offer helpful efficiencies. The documentation and reports from the pilot project will be invaluable. WAVE will be partnering with the Maryland Department of Aging on projects to encourage and support villages across the state. There are many counties that have no villages at present. The hub and spokes model is an attractive option for both county agencies and established non-governmental entities wishing to help initiate sustainable villages in their area. The lessons from the current pilot project will help inform their decision. Maryland will help support the pilot project itself through our various programs and services. I hope you will support this bill.
Thank you very much for being with us. I'm going to open it up for questions now. Are there any questions for this panel? Seeing none, thank you very much for being with us. We really appreciate your time. And Delegate, it was great having you in our committee. And I hope you have a blessed day, okay? This actually concludes the bill hearing on House Bill 1103. Next, we're going to House Bill 874, and that is State Boards of Long-Term Care Administrators, requirement for assisted living managers. May I please have Secretary Roque, Linda Burrell-Ward, Donna Kaufman, Tommy Bresnahan, yes, you are. Okay. All right, thank you so much for coming. This is actually a bill I introduced. So I want to say, Madam Vice Chair and colleagues on the Health and Government Operations Committee, thank you so much for allowing me to present House Bill 874. So why did I introduce this bill? In 2022, the committee passed House Bill 1034, which renamed the State Board of Examiners of Nursing Home Administrators to the State Board of Long-Term Care Administrators, and required that the board must license an individual to practice as an assisted living manager in the state by October 1st, 2024. In addition, the bill required managers in small homes to be required to take an 80-hour training, which they previously were exempted from taking. So why is the bill here? This is a large undertaking, and we want to make sure that the board has the necessary tools and resources to be successful with their task. So what does this bill do? This bill, House Bill 874, does the following. It extends the time frame for the board to license assisted living managers from October 1st, 2024 until July 1st, 2026. So it extends it by 2 years so they can do their work. It provides the same time frame to the managers working in small homes to take the course. The objective of the law is to guarantee that long-term care administrators in the state of Maryland have the necessary tools and to be able to take the training to assist the people in need. If you're asking what other states are doing this, has it been done before? Other states like Delaware, New Jersey, and New York have already implemented requirements like this for their assisted living managers. These changes are necessary to ensure the best quality of care for Marylanders, no matter the type of assisted living facility they live in. I want to thank you so much for allowing me to present to you House Bill 874. Now I'm going to call the following witnesses. You have 2 minutes to present your testimony. The first one is Secretary Roque. Thank you for being here and for working with me on this.
It's a pleasure to be here. And Vice Chair Cullison and committee, thank you for allowing me to testify in support of this bill. You have my written testimony, so I'm going to just hit a few key points. We all know Maryland is a longer lived state and people are growing older, faster, and that these kinds of models of care need to be supported. Assisted living facilities are a crucial piece of our long-term care ecosystem and economy. Small assisted living facilities of 4 beds or less are often located in residential communities and have tremendous potential for growth to fill the unmet need statewide for high quality, affordable assisted living. Key points here being high quality and affordable. One of the best things we can do to promote growth in small assisted living sector is to ensure that the state regulations of them are reasonable. With sufficient advance notice of new requirements, realistic ability to complete them, and a functioning statewide coordinating entity to make sure all of this happens, we should be able to successfully see our assisted living managers tested and licensed. Those pieces are in place now, but they were not for a significant time, as you heard earlier, and now it's time for us to address the shortcomings in the original bill. I do believe that by changing the bill to give additional time for meeting the licensure requirements to the small facilities will in fact grow our small assisted living sector and help us better meet the needs of older people in Maryland. I urge a favorable report for House Bill 874.
Perfect timing. Let's see if you can follow that. Go ahead. Good afternoon.
Good afternoon, Vice Chair, members of the committee. My name is Linda Burrell-War. I am the Executive Director for the Maryland State Board of Long-Term Care Administrators. I would like to thank you for the opportunity to express the board's support for HB 874. Extending the implementation date for the licensure of assisted living managers from October 1st, 2024 to July 1st, 2026 will provide the board with the additional time for planning and procurement for resources and expertise as we construct the necessary framework to ensure that organizational, operational, and IT infrastructure will support the likely 8-fold increase in workload to prevent the disruption of our regulation of both assisted living managers and nursing home administrators. In order to successfully implement the licensing requirement and continue on our mission to promote quality healthcare in the field of long-term care, the board must work in coordination with the Office of Healthcare Quality, the Maryland Department of Aging, and the applicable trade associations. Unfortunately, the board has faced significant hurdles over the past year, which has delayed progress in moving forward. The executive director and deputy director resigned last year, and I was hired as the new deputy executive director in December 2023. The regulations for assisted living manager licensure need to be promulgated. The board has 3 assisted living manager board seat vacancies, an inadequate online licensing renewal portal, and no automated process for all board functions. The Office of Healthcare Quality addressed the insufficient number of training vendors and the time needed to review the training curriculums from new vendors. The Maryland Department of Aging voiced concern about the potential disruption of board operations, the financial impact for those assisted living managers who were previously exempt from the costly 80-hour training course, and the limitation on various training methods, all of which may create barriers for assisted living managers to successfully meet the licensing requirements. In conclusion, the board believes it can meet the challenges faced if the implementation date is to July 1st, 2026. Thank you for your consideration. The Maryland State Board of Long-Term Care Administrators respectfully request a favorable report on HB 874.
Thank you for your work on the board. We really appreciate it. Next, please.
Thank you.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Dana Kaufman. I'm here on behalf of Lifespan Network, and we're in strong support of House Bill 874. Our main goal in supporting this bill is to make sure that we can have a seamless transition for the licensure of assisted living managers, and that in doing so, we also do not end up disrupting the important task of licensing and the renewals for the nursing home administrators. Remember that this board is already tasked with the oversight of nursing home administrators. And just to emphasize, this is an eightfold increase in the responsibilities of this board. So we do need to be very careful and make sure that they have the support and the resources that they need. This is not something that is unique, needing extra time, especially when there's been a switch in administrations. The Department of Labor has now come twice back to the General Assembly for extensions on their implementation of the Family and Medical Leave Insurance Act. And again, that is being done to ensure that they have the resources necessary to have a smooth implementation. In deciding whether or not or what should be the extension for both the licensure as well as taking the 80-hour course, we looked at everything and we considered, is one time sufficient or do you need longer? And given the hurdles that need to be solved, especially the electronic licensing, we felt that with the board's support and working with the Department of Aging and Office of Healthcare Quality, that we really did need to make sure that they had sufficient time. And that's why we came up with July 1st. So with that, I appreciate working with the board. I'm excited to work with the board to make sure that all of our managers can be licensed in a very smooth process. And I would ask your favorable vote. Thank you.
And thank you for your work on this issue and many others. Appreciate it. Next, please.
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Tammy Bresnahan. I'm the Senior Director of Advocacy for ARP Maryland. You have my written testimony. We do have concerns. We appreciate everything that you've done, Madam Chair, by submitting the bill in 22. We have been working on this issue since 2005. It came to the Department of Health's attention in 2005. And there was a report issued, and I have a copy of it if you need it, that residents in assisted living confirmed that residents in assisted living are frailer and have more memory issues than when OHCQ began regulating the industry. They were supposed to upgrade their regulations in 2008, and we are still waiting. I have 152 pages of regulations with comments that have yet to be submitted to be promulgated. The advocacy community understands that there was an agreement reached by the industry, the Department of Aging. We've been working on this issue, like I said, since 2005, and we were kind of left out of those discussions. So this bill was a little bit of a surprise to us. I also sit on the Oversight Committee, and I was again surprised that this bill was being introduced, as well as some members of the advocacy community. We believe that residents in assisted living need the best possible care, and that begins well-trained staff. As one of the advocacy organizations that supported your bill, we have ongoing concerns about extending the timeframes. But like the Ombudsman has put a bill in with support with amendments, she would rather see 2025 rather than 2026. And we'd like to see timeframes, a performance plan timeframes, and a progress report. As I wind down my career, I'd like to see more attention to assisted living. We ask you for support with amendments. Thank you.
Thank you. And you know that I always get in touch with everyone. So I put in the bill in order for I was asked for it to be addressed. But you have my number, so it would have been nice to hear from you, and then we
dropped it off. So I didn't, we dropped off our testimony. So
yeah, but in the future, call me, okay? Because that's how I operate. So I apologize that you're not at the table, but it's really tough for them to do the work. And if what happens is we put 2025, we'll be back in 2025 to ask for more time. But you're going to come to the subcommittee and you can, talk about it in the subcommittee and see what you can do. You usually do your magic. So you could do your magic in subcommittee as well. I'm going to open it up for questions. Are there any questions for this panel? Okay, so the bill is going to go to subcommittee because they can do the work. So let's see if we can find a compromise. They were always open to compromising here, okay?
Thank you.
And call me if you need anything. You have my number.
Certainly.
Okay, thank you. So next we have, if I may, a favorable with amendment, Megan Peters, and we have Stebane Ellis. Will you be so kind and bring them up? Thank you. Hi, Megan.
Good afternoon.
How are you?
I'm doing well. How are you?
Good. It takes a little taking used to see you in that new role, but you're doing it well.
Thank you.
Go
Thank
ahead.
you for having me today.
You're welcome.
So good afternoon, committee. Again, my name is Megan Peters, and I'm the Director of Government Affairs for the Alzheimer's Association here in Maryland, here today in support of House Bill 874 with amendments. As my colleagues had said previously, assisted living facilities are supporting many of our most vulnerable older adults. And nationwide, it's estimated that 34% of these older adults have some form of Alzheimer's or dementia. Really excited that the body passed legislation in 2022 to establish licensure and training requirements for assisted living managers to create more oversight and especially protect our most vulnerable older adults with dementia who are subject to abuse. The association recognizes that there are unexpected challenges that can arise in developing and implementing new licensure and training requirements, including staffing and IT challenges, which I know were noted in the board's report this past fall regarding progress towards implementation. We understand that there were conversations that occurred regarding the delay in implementation and know that there was a lot of thought put into the request for an extension, as this is a policy that so many of us are supportive over. We're encouraged that the governor's fiscal year 25 budget includes funding for 3 regular positions for the board to support licensing, investigation, and other duties. But still, given the challenges the board has faced, we do support that an extension, but are respectfully requesting a shorter extension just so that we can have that additional protections in place for our vulnerable older adults. I'm happy to work with the subcommittee, participate in discussions and compromise. And we also urge the committee to request the board provide additional reporting regarding implementation, specifically an action plan outlining key deliverables towards progress so that we can ensure that they are meeting that extended deadline. Thank you.
Thank you. Are there any questions for this witness? Please come to subcommittee, okay?
Thank you.
I have one more witness, Allison. Is she here? Okay, great. She's supposed to be here. Okay, thank you. Michelle just saved me.
No problem.
I was gonna leave you out. Thank you, Michelle.
Thank you.
You're
Thank you,
welcome.
Madam Chair, Madam
You're
Vice Chair, and members of the committee. I'm Allison Siborowski, President and CEO of Leading Age Maryland. We represent about 150 different not-for-profit aging services communities across the state, and our members provide services, care, and housing to about 20,000 older Marylanders every year. As Secretary Roque mentioned, assisted living is a critical component of our LTSS long-term services and support system here in Maryland. We represent about 50 not-for-profit organizations who provide assisted living care, including numerous mission-driven organizations who have found a way to subsidize the cost of care and offer affordable, quality assisted living. Given the continuing workforce challenges facing our field, we cannot afford to lose even one assisted living manager. At this time, the infrastructure for this change in process is not established to the point where licensees and the board can move forward effectively. Managing the licensure for assisted living managers will be a wholly new responsibility for the Board of Long-Term Care Administrators. And as Dana Coffin mentioned, this is a huge increase in the number of individuals that the board will be responsible for licensing and overseeing. The additional time to prepare for this change provided for under the bill is necessary to ensure that both the board and licensees have the appropriate time to prepare for the transition. For these reasons, Leading Age Maryland respectfully requests a favorable report on House Bill 874. Thank you.
Are there any questions for this witness? Seeing none, thank you so much. And thank you for your patience. And we're now going to go to the last witness for this bill. Good afternoon. How are you?
Hi, I'm fine. Thank you so much for giving me the opportunity to testify on this bill. I'd like to thank the chair, the vice chair, and the other members of this committee today. My name is Savannah Ellis. I'm the State Long-Term Care Ombudsman. The Ombudsman program is the advocacy program for nursing home and assisted living residents. I am also a member of the board of nursing home administrators and assisted living managers, but I'm testifying today as the State Long-Term Care Ombudsman. I wanted to tell the story of assisted living residents related to concerns we have when we have managers that don't take action or inaction properly. It can lead to harm abuse, exploitation, benefits trafficking, and other issues. And so I'm very supportive of assisted living managers being licensed and having their professional standards that will help with the integrity of assisted living residence facilities across the state. And this is to protect residents against bad actors. So I'm very supportive of this bill. I, however, note that I believe the extension waiting till 26 is too long. I'm proposing an amendment that will allow the board to do the work by the end of 2025. And if at that time there's issues like Linda Burrell Ward mentioned, then extending the time period until 2026. I also requesting that when in-person training is needed because of interaction with the faculty of the course, that be added to the law. It was omitted. And also there is a date in section 9401.19 that I believe that date also should be the date of the law when it goes into effect. I really appreciate you all hearing me today. And if you have questions, please feel free to contact me. I'm requesting a favorable review of this bill with amendments. Thank you very much for your time.
And thank you for being here with us today. Are there any questions for this witness? Seeing none, please come to the subcommittee, okay? So that the subcommittee can work with you and you can compromise on the language, okay?
Yes, ma'am. Thank you very much.
My pleasure. This actually, this is there. I'd have no other witnesses. So House Bill 874 is done. Let's move on to Delegate McComas says she has 2 bills in judiciary. So let's go to Delegate Woods, 1120. Oh, she's here? Oh, because I have a note here. They said that you had 2 bills in judiciary. Okay, let's do it. Thank you.
Yeah, I don't think I've ever had 3 bills in one day. So
That's okay. It
Murphy's Law.
happens. It happens and we're flexible. So thank you for making us a
I just
priority.
want to get Mr. Flack seated. And
Yeah,
then
take your
we'll
time.
commence.
Take your time.
There we go.
And Delegate Hill, thank you for looking out. I just looked at the note. Thank you. Take your time.
This is a simple bill, but as we all know, simple bills could get very complicated.
That's right. We never said that here.
We have a lot of cooks in the kitchen or a lot of authors, and some are Shakespearean and others are kind of not Shakespearean. Anyway, this is in support of testimony for HB 1289, State Board of Social Work Examiners, Practice of Social Work, Definitions and Scope of Authority. This bill amends and expands the definition of the practice of social work to clarify scope of practice and codify the duties of an LCSWC. It further supports and sets forth the authority of the State Board of Social Workers Examiners to adopt regulations that outline the requirements for engaging in the practice of social work that are not already in statute or regulations. Among my panel here is Mr. Arthur Flax, a longtime practitioner of social work in Maryland. His knowledge, training, and experience is the foundation for his unrelenting efforts in bolstering the ethical and responsible practice of social work, while expanding the parameters of the practice for every LCSWC in Maryland. This bill expands the definition of the practice of social work for a licensed LCSWC to include authorizing sick leave in certain situations, certifying involuntary admissions in accordance with the law, certifying competency in accordance with the law, determining eligibility for disability in certain situations, determining eligibility for mobility programs, acting as a healthcare provider in certain situations, and acting as an authorized provider for the purposes of workers' compensation. Expanding the scope of authority and practice of social work would alleviate the shortage of generally healthcare providers in many situations and provide crisis intervention when most needed. It's a no-brainer bill, so please enter a favorable report for 1289. Mr. Flack, you're on.
Good afternoon.
Good afternoon, sir. How are you?
I'm fine. Thank you for having us here today. This bill clarifies for the Board of Social Work Examiners, the practice of social work. The statutes and COMAR, which Delegate McComas mentioned, are currently in law. Those are active statutes. What this bill and that part is asking is to cross-reference those statutes into the Board of Social Work Examiner statute. So someone doesn't have to be an attorney shepherdizing cases in order to find out what a social worker can or cannot do. It's not expanding the practice of social work. It's not asking that. Those laws already exist and have existed. What we're asking here is to clarify the definition of biopsychosocial, so to bring it in line with the current federal CMS rule, CFR final rule of section 4121, which went into effect January 1st, 2024. Is to put that, we have biopsychosocial under the scope of practice. This just moves it, but there's no definition in our statute. This just moves a definition to the statute. I looked as to biopsychosocial to clarify that definition. Hillary Clickler, Alcott with the MLIS wanted to change the word from treatment to analysis to make it more for legal sufficiency. Just a technical. The Board of Social Work Examiners that I've been in touch with, they are concerned about, they say here, State Board of Social Work Examiners are writing this letter of concern on HB 1289. While we do not have issues with clarifying aspects of the practice of social work, the support of the ability to expand the scope of a licensed or the ability to expand the scope of a licensed certified social worker clinical, there is concern with the language on page 4, line 18, require board certification. We asked in the bill, Lisa Simpson, senior policy analyst, helped draft the bill for me and for legal sufficiency purposes, and she used the Board of Nursing as a guideline. My license is a licensed certified social worker clinical, so it seemed to be contradictory, so we put that term in there so that the board, if they wish to, they could certify specialty practice for competency. They don't want to do that, that's fine. They can delete that. We have no objection to that. The rest of the other parts they approve of. That's basically what it is. It's a matter for it's a technical bill to clarify the definitions for this, and so somebody can look at the bill and know what a social work practice encompasses in the state of Maryland.
Okay, thank you so much for your testimony. I'm going to open it up for questions now. Are there any questions? Delegate Lewis.
Chair, and thank you, Delegate McComas, for bringing the bill. Welcome to HGO, where we welcome everybody. And I appreciate the thoughtfulness that went into refining the way we determine social work licensing and the terminology. I was wondering if you were aware that last year, the legislature passed a bill to create a work group on social work licensing.
Yes, ma'am.
Yes, and thank you, sir. And specifically to you, have you been able to participate, and have you found a welcoming environment for sharing your suggestions? Because that work group would be a great place to talk about this.
I have been involved when Stanley Weinstein was a director of the Board of Social Work Examiners. I was a volunteer consultant with the board and have done work with the board over the years. When Jane Pilliard was the Assistant Attorney General working there, and Jack Schwartz, I was a consultant for them. So I've been involved with them, and many of the statutes that have been enacted that are outside of the Board of Social Work Examiners, the ones that Delegate McComas alluded to, I wrote those. I worked and put those bills, got those bills initiated and enacted.
You're welcome. I have Delegate Kaiser followed by Delegate Hill.
Thank you, Madam Chair. Delegate McComas, my question is for you. I'm looking at, I don't know if you saw the opposition testimony from the Maryland Board of Social Work, as well as the letter of information from the National Association of Social Workers, which essentially was unfavorable as well. I was wondering if you saw the testimony and had any reactions.
Delegate Kaiser, I did, but I am not a social worker. So Mr. Flax probably is the better person to ask the question. So, because he actually did look at the information.
I've been involved with NAS. I'm a member of NASW. I've been involved with them. I've talked with people from the School of Social Work. I've seen the materials that you're referring to. The reaction is that this social work, the school of social work primarily teaches values, instills values. More than half of the social workers practicing are not LCSWCs. They are master level social workers. They changed it from licensed certified social worker to master social worker. But the bottom line is they only have title protection. They don't engage where there's practice protection and restricted duties. Their duties are 100% fungible with a non-licensed person. They are not interested in more regulations to assess competency in specialties. They don't need it.
I have, Delegate Hill doesn't have her light on anymore. Okay, Delegate Collison.
Thank you, Madam Chair. So I'm going to dig a little bit deeper, Mr. Flax, into Delegate Kaiser's question. They specifically speak to the notion of biopsychosocial as not being a treatment, a kind of assessment that they might do, and that it's definitely just an approach. And then the other part is on the last page of the bill, it says that language is duplicative. In one letter, it says the language is duplicative in terms of allowing the board to adopt regulations regarding requirements. And one of the other letters said that requiring board certification would be a challenge since the board does not certify. So thoughts on those?
Yes, ma'am. Let me start with the certification. My license says licensed certified social worker clinical. It seemed to be contradictory. If you look at their test at the Board of Social Work Examiners testimony. So I worked with Lisa Simpson, Senior Policy Analyst for MLIS. She drafted the bill for legal sufficiency. I gave the ideas of what we needed, and I worked closely with her, and I took her guidance, what she wanted. It just seemed contradictory in one place that they license a person as a licensed certified social worker clinical, and then they say, we don't want to certify anybody. We don't have an objection to deleting that part. I don't have no objection. Christine Crone, who's also an attorney and a lobbyist for the Greater Washington Society of Clinical Social Work, she put in there that it was duplicative and it could be eliminated. We have no problem with that. We have no problem if the board taking out what the board wants in there, which was required board certification. We thought it would help the board to be able to assess competency in certain areas. Clinical social workers have the authority to be a secondary signature on guardianship and on involuntary commitment, as an example, and in other areas that affect people's lives. But some people don't know how to write, don't know how to do that. They don't know what the law is around it. There's no reason that the board could not certify somebody if they took the proper courses to do that, to assure that people doing that work, presently it's up to the person to take the course on something on their own, and only when there's a complaint to the board that somebody did something wrong do they get involved. So we thought it was a good idea to give the board the authority, but if they don't want the authority, that's fine too.
Thank you. All right, thank you. Any other questions? Seeing none, thank you for being with us today. We really appreciate it.
Quite welcome.
All
Thank
right.
you.
Thank you, Madam
And
Chair.
actually, Lisa is watching she's actually watching all these hearings today. Okay. Next, we have Christine Crone. And we have Daphne McClellan from the Maryland Chapter National Association of Social Work for information. All right, how are you?
Good afternoon, members of the committee, Chair Pena-Melnick and Vice Chair Cullison. My name is Christine Crone, here on behalf of the Greater Washington Society for Clinical Social Workers. And I just would like to clarify for the record, I am not an attorney. I just work for very smart attorneys. But nonetheless, we're here to testify in support with amendments on House Bill 1289. We really appreciate all of Arthur's hard work and with his intent in trying to strengthen the statute around social workers and what's included in their scope of practice. As you've heard, there's a couple differences of opinions around the term biopsychosocial. For your information, it's referenced on page 2, line 10, and the term refers to developed as a model of how to think about clients' issues that encompasses their biology, psychology, and social environment. We were trying to work out the terminology that should be in the bill last night in preparation for the bill hearing, but I don't think we're quite there yet. So we would appreciate working with all the stakeholders at the subcommittee level on this, and happy to answer any questions.
Thank you very much. Next, please.
Good afternoon, Madam Chair and members of the committee. I'm Dr. Daphne McClellan. I'm retired from being the director of NASW, but since the current director was unavailable today, I'm here actually representing NASW this afternoon. We have introduced a letter of information. There are three things that this bill does. It first deals with the issue of the biopsychosocial model. There is no such thing as biopsychosocial treatment. And we believe that this is already addressed in the statute regarding the social work practice, because it particularly refers to the treatment of biopsychosocial conditions. That's already in the bill regarding in the law regarding social work practice. And so we don't think that this is necessary. Secondly, we believe the Board of Social Work Examiners already has the authority to promulgate whatever regulations they feel are necessary for the profession. So we don't believe that the last part of the bill regarding, giving them additional authority is necessary. And thirdly, it is helpful, I think, to have all of the statutes and other parts of the law that might refer to social work practice. But if we put them in here in this bill, then does that mean that every time something else in some other piece of the law addresses social work practice, we'll have to have another bill adding them in? So we think probably having a list perhaps on the Board of Social Work Examiners website regarding, where you can find other items that refer to social work practice might be more helpful than having to come back to the legislature each time there is something written in other parts of the law. So those are our issues, and then we just wanted to bring them to your attention. Thank you for allowing me to speak.
And thank you for being here with us. Are there any questions for this panel? Vice Chair Collison?
Oh, thank you, Madam Chair. So I guess I want to, I don't want to put you on the spot, Dr. McClellan, but I want to ask the question. I'm sensing that the National Association of Social Workers is feeling like the bill is not necessary. Is that
I think
what I'm hearing?
I think, yes, we're not opposed to the bill necessarily, but we don't think that it's particularly helpful and necessary.
Okay. Thank you. Any other questions? Seeing none, thank you so much for being with us today. We really appreciate it. This actually concludes the bill hearing on House Bill 1289. Delegate, thank you for being with us today, and good luck in judiciary. Next we have, I'm going to call House Bill 938. And thank you, Delegate Woods, and for being patient. I'm sorry, the secretary's here and he's been waiting for a little while. Okay. Okay, good afternoon. How are you, Delegate?
Good to see you, Madam Chair,
Nice to
Madam
see you.
Vice Chair, members of the committee. For the record, Delegate Brian Crosby. I'm here with Delegate Woods' 15th cousin, Secretary Woods, here to present House Bill 938, state-owned nursing homes, deficiency citations, fines, and reporting requirements. Many of you remember last year, and I want to thank this committee personally. We passed an emergency bill dealing with the mistreatment that was going on with Charlotte Hall Veterans Homes. To the Secretary's credit, they have made significant changes there, and I believe that we are on the right path. But there's still, I guess, this question about what if this happens again, and how do we prevent that going forward? And so all this bill does is, frankly, it's a cleanup bill. It just adds a couple different agencies so that the reports are issued to several groups such as the Department of Labor, Local Health Department, the U.S. Department of Veterans Affairs, or OSHA. And it clarifies that contractors should provide notice of a deficiency or enforcement action within 15 days of the final survey finding rather than promptly. It also requires that within 30 days after the contractor's final acceptance of a plan of correction or completion of an informal dispute resolution, the department charged with the oversight of the nursing home shall provide the plan of correction or results to the aforementioned informal dispute resolution. So that's the bill in a nutshell. I asked for a favorable report, and I want to thank you and the Secretary for being here.
Thank you, Delegate. Good afternoon, Mr. Secretary. How are you?
Doing very well. We're working through my homework assignments for you, ma'am.
I gave you a lot of homework last time you were
Afraid to get
here.
more of them.
You can blame it on my committee.
No, they're very good clarifying assignments. So thank you, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. For the record, I'm Tony Woods, Secretary of the Maryland Department of Veterans Affairs. I'm honored to appear before you today in support of HB 938 and respectfully ask the committee for a favorable report. We were honored to work in partnership with the legislature to pass this legislation that requires contractors operating state-owned nursing homes to provide notice of deficiencies and enforcement actions that are levied at a facility. When I came before this committee last October, I spoke about the transition to the new contractor, Pruitt Health, the reforms we've invested in, and how we are working to transform the facility and how that work has only just begun. Since Pruitt Health took over, we've worked in lockstep, really focusing on changing culture and improving performance. Today, I'm proud to say that we rely upon real-time dashboards that provide up-to-the-minute information about quality measures. We leverage a 6-person quality assurance team employed by the MDVA that conducts regular audits and spot checks. We also do, of course, rely on regular inspections from outside agencies, which this bill addresses. And then, of course, the mandatory reporting as a result of that law is incredible for maintaining transparency. We're incredibly thankful for Delegate Crosby, Senator Jack Bailey, Delegate Matt Morgan, Delegate Todd Morgan for their leadership on this. This bill, of course, holds my department ultimately responsible for notifying you all, along with relevant stakeholders. This bill also expands the list of monitoring agencies to the full range of organizations that play a role in ensuring that we maintain high standards. And then finally, this bill clarifies the reporting timelines, as you mentioned. I'll simply close by kind of going off script here to the dismay of my team, but I wanted to say it's been a privilege working with so many of you throughout this process. What I've realized in the year since we've brought this to everyone's attention, that people didn't approach us as Republicans or Democrats. They approached us as delegates with constituents that they were concerned about. And this law, we think, helps to ensure that we provide you with timely information.
Thank you, and thank you for your work and for working with our committee and our members on a lot of these bills. We really appreciate it.
Of course, thank you.
So I am going to open it up now for questions. Are there any questions for this panel? Delegate Morgan.
Thank you, Madam Chair.
You're welcome.
Mic's on, good. Secretary Woods, I want to congratulate you in cleaning up this situation that was really a bad situation left over from the last administration. You guys had this dumped on you. You took a lot of leadership and really kind of took control down there. So I really appreciate it because that was, I mean, you replaced the main management company for Charlotte Hall. So it was a big task and your team really took it seriously and really has done a good job. On this bill, I guess the question is for the bill sponsor. We had some pre-session meetings with our county commissioners, and local government's not in the notification at all in this bill. Should we add them?
I know that they have proposed an amendment. Obviously, it is now the committee's work, but frankly, no, we didn't include them because typically the state isn't going to report down. But I mean, if that's y'all's decision, then I'm okay with it. I don't have ton of heartburn over it.
And Delegate, I would simply say that we have found the local county commission to be a really important partner for us. They also, in the case of Charlotte Hall, I can't speak to all nursing homes. They are actually the responsible party for a number of residents who live there. So we have always felt that we have an obligation to share that information with them.
Sure.
Yes. Real quick follow-up. Thank you, Madam Chair. I guess as the bill is drafted, it's not a local St. Mary's bill. I just want some clarification. It really only affects two areas, right? St. Mary's County with their delegation. And I guess it would affect Carroll County as well because you're out there building a new facility. You want to give some comments on that?
You're absolutely right. One of the things that I've pointed out is that it's incredibly important that loved ones, family members, responsible parties have good insight into what's going on into their loved ones' lives. And so proximity really does matter here, which is why we're excited to continue to push forward on opening a second home in Sykesville, Maryland, which will make it geographically accessible to a lot more Marylanders and provide additional capacity for veterans in need.
You're welcome. Delegate Hutchinson,
Well, thank you, Madam Chair.
you're welcome.
Thank you for both of you for the great work you did with Charlotte Hall last year. I remember hearing about that and what was going on there. And so yesterday, and I'm not sure if this is apples and oranges here, but so yesterday the Attorney General is here, he wanting oversight of certain components, including nursing homes. Now I see this, and then you're adding more oversight. And I keep coming back, and I sort of wanted to ask the question yesterday, and I don't know whether you can answer it or not, but I keep going back. We have this Office of Healthcare Quality. Is that not working? And should we really be looking at, we got to get that fixed?
I'll be the first one to tell you, Delegate, I'm not familiar with that specific agency. This is a reporting bill. So that's what this does. And it arose out of the situation last year from Charlotte Hall. And when there is a report made, it was only going to the people at Charlotte Hall and nobody was aware until things blew up. And so all this bill does or seeks to do is add to the list of who gets a copy of the report. So that way more people are notified and we can get out in front of the problem instead of finally somebody leaving a binder on another individual's desk during a transition. And all of a sudden there's 9 million news reports, et cetera. And we're all finding out about this, and to include, many people on this committee who had to deal with that issue. That's all it's doing.
I would echo that. I think Delegate Crosby has it exactly right. I view this as a transparency bill where we have an obligation to make sure you are fully equipped with the facts.
Okay. Usually we allow one person, but I bet it must be because I had a piece of chocolate that I am like enjoying the chocolate and not paying attention. But anyway, it's all good. It's all good. Delegate Hutchinson. Delegate Hutchinson, can you hear me? I have some ideas about that question that you just asked. So can you please make sure we talk today? Are there any other questions? Okay, I'm paying attention now. Okay, thank you for your testimony. Thank you, Secretary Woods. Look forward to getting that homework assignment.
Yes.
Make sure the dog does not eat it, okay?
Absolutely. And I can report back in real time. Secretary Grady reached out. We are finalizing the details and we'll be in touch soon.
Thank you so much. We do have one more witness for your bill, and that is Mr. Kirk McCauley. And is he here? Okay. All right. Let him know that we did call him. So this will actually, this is it for this bill. House Bill 938. We're done with it. Let's move on to Delegate Woods. I apologize, but I have to call this next witness. This next bill, I'm sorry. I'll give you an extra. Oh, okay. So House Bill 939, we just concluded the House Bill 938. So we're going to start now on House Bill 939, Delegate Palakovich Carr, Health Insurance. Why don't you go ahead and present the bill?
Thank you. And if maybe my sponsor panel can come up while I'm speaking
Absolutely.
too.
Why don't you have them all come up?
Great, thank you. And well, Delegate Woods just stepped out, but my sincere appreciation to her. I have a bill in another hearing that's
And I
about to get-
believe you have Jason Lindet, Robin Elliott, Liz Elliott, and Mukta Bain. I hope I pronounced it correctly.
Great, thank you. Well, good
You're
afternoon. For
welcome.
the record, I'm Delegate Julie Palakovich Carr, here to present House Bill 939. This is an epinephrine injector. I carry one with me at all times because of my son's life-threatening food allergy. He consumes even a very tiny amount of the food that he's allergic to. Within minutes, he will start to break out in hives. He'll have trouble breathing. His throat will start to swell up. And unless this is injected into his leg, he actually could die. And unfortunately, he's not the only kid or person in Maryland who is like this, who is at risk of anaphylaxis, one of these life-threatening allergic reactions. There are hundreds of thousands of kids and adults in Maryland with a severe food allergy or allergy to bee stings. And these Marylanders must always have access to one of these injectors. You might know by its brand name, an EpiPen, in case they are accidentally exposed to their allergen. Again, otherwise they can die. The problem is that epinephrine injectors have increased dramatically in cost in the past decade. A 2-pack of the name brand medication went from $100 to $600 simply to fuel corporate profits. And according to data from the Maryland Healthcare Commission, a patient typically purchases 3 2-packs each year at an average cost of $70 per box. But that average cost is misleading because it includes a multitude of Marylanders who, like I'm guessing like most of us in this room, have good health insurance. So for instance, I just refilled my son's prescription. I'd paid $10 for a 2-pack for generics under the state's health plan. But on a high deductible plan, someone else may spend as much as $700 per box. And some patients simply can't afford to fill their prescription and will risk going without it, even though it could cost them or their child their life. And even more scary is that there are families who have children with a very severe allergy who simply just don't disclose the allergy at school or summer camp or after school program, because if they disclose the allergy, then they have to provide the prescription. Otherwise, their child cannot enroll in that program. That's not true for public schools, but for other types of care, that is true. And in fact, I've been told by the director of the recreation department for my county that this happens too frequently, that parents don't disclose because they can't afford the prescription. They need their kid to be in that summer camp so that they can go to work. And so then the counselors, the staff are not able to take the preventative measures to prevent that child from being exposed to their allergen and to prevent the allergic reaction to begin with. So knowing all of this, my initial thought was actually not to do a bill, but to go to the Prescription Drug Affordability Board. And thanks to the good work of this committee and of the chair, you know, they are a great resource. And I asked them over the summer, what could we do about the price of EpiPens? And they agreed this was a big issue and they looked into it. And they came back to me in the fall with the following, quote, EpiPens are likely not a strong candidate for upper payment limits. Maryland has the unique authority to implement upper payment limits for state and local governments on drugs that cause affordability challenges. However, EpiPens are likely not a good candidate for current upper payment limits because they do not cause issues for state and local governments, end quote. And that is borne out in the data that the Maryland Healthcare Commission provided, as I referenced earlier. So PDAB did, however, recommend that a copay cap could be a viable option to address this. So it's for all these reasons that Delaware, Colorado, Illinois, and New Jersey have passed legislation to cap out-of-pocket costs for patients for this life-saving medication. This bill will ensure that families don't face a situation of being unable to afford this necessary drug by capping the cost of epinephrine injectors at $60 per box. Most insurers in Maryland already charge a lower copay. This bill is needed to protect patients in high deductible plans so that they don't go without this life-saving medication. And let me just lastly add that just a few hours ago today, we heard from the MIA about the need for a technical amendment to ensure that the bill doesn't conflict with federal requirements related to health service account compatible high deductible plans. And we're requesting that amendment and we'll get that to the committee when we have it. Thank you.
Thank you. Next, please.
Good afternoon, and thank you for your time. I am Elizabeth Elliott, President of the Maryland Association of School Health Nurses, and my mission is to help our state's children grow into healthy and thriving adults. I live and work in Montgomery County, and one of my children carries an EpiPen. We share our strong support for House Bill 939 because it just makes sense for kids. it limits copayments for life-saving epi in a similar fashion to insulin. According to the Allergy and Asthma Network, 1 in 20 Americans have experienced anaphylaxis. And what this means, in a classroom of 30 students, at least one student has anaphylaxis. If not treated right away with epinephrine, anaphylaxis can be fatal. But because of these high out-of-pocket costs, many Maryland families don't have immediate access. School nurses know that we need to treat anaphylaxis right away. We also know that people with anaphylaxis need access to a twin pack or 2 epi auto-injectors because the medicine is only active for 10 to 15 minutes. And what we see at school is too often families either don't provide the prescription to school, don't fully disclose the condition, or they only provide 1 EpiPen and they split the dose, 1 for home, 1 for school, putting children at risk in both spaces. This is especially the case in Title I and community schools where families just don't have the resources to buy those 3 twin packs for all locations. Again, I urge a favorable vote on House Bill 939 with a technical amendment because it would provide common sense cost sharing limits. Thank you so much for your time.
Thank you. Excellent timing. Next, please.
Good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Nurses Association in full support of the bill. And I'll just highlight 2 things. First of all, it is absolutely true, adults and children both can have food allergies, but we looked at the research and we looked at the data and wanted to note that 63% of claims in Maryland, this was in 2022, for this product were for children. So this disproportionately impacts kids. And then the second thing we just wanted to note, and we supported the legislation that you all enacted in 2022 with, I believe it was a unanimous vote in both the House and the Senate to establish a similar structure for insulin. It was only a couple years ago, so I'm sure you remember it. Maryland is now one of, I believe, 25 states that have enacted that. So this is really something very similar for a similar type of life-saving medication that disproportionately impacts children. Thank you very much.
Thank you.
Madam Chair and members of the House Health and Government Relations Committee, my name is Jason Lindy. I'm the Senior Vice President of Advocacy at FAIR, which stands for Food Allergy Research and Education. We're the largest nation's nonprofit dedicated to food allergy advocacy. I'm here today on behalf of the more than 623,000 Marylanders with life-threatening food allergies. We're here because we're in strong support of Delegate Palakovich-Carr's legislation, HB 939, which would cap epi auto-injectors at $60. I'm also a Maryland resident who had a dairy allergy, and my son is allergic to shellfish. Maryland's food allergy population is larger than the county of Anne Arundel. So just let that sit in for a second. This is 1 out of every 10 Marylanders has a life-threatening food allergy. And unfortunately, they're growing at a faster rate among children who are African-American, Latino, and Asian American. The only medicine that keeps us alive is epinephrine. And for the last 10 years, the price has skyrocketed with generic versions now costing between $320 and $750. To make things worse, the medicine in this EpiPen costs $1. It takes $8 to manufacture, $8. And yet, because more than 40% of the state's food allergy families are in high deductible health insurance plans, they're paying anywhere between $1,000 to $1,400 in out-of-pocket costs because their children need a pack at school and a pack at home and somewhere else. Now, the insurance companies love to blame pharma for this problem, but they fail to mention their own role in this situation. They use pharmacy benefit managers or PBMs to negotiate their rates with pharma. The blame game is going on in Washington, D.C. right at this moment, too. There, though, pharma is blaming the PBMs and the insurers. The blame game goes on, we keep paying more. And the insurers also like to mention rebate cards and rebate programs. Look, we run the biggest nonprofit, if I may have 20 seconds to finish.
Sure.
We run the biggest nonprofit, and the problem with these rebate programs are a few. They're onerous, they're burdensome, and they don't help working and middle-class families because they're income-based. I'll finish with this. Last month, the Wall Street Journal said, insurers are raking in profits while customers pay soaring premiums. That was their headline. Insurers have made record-breaking profits the last 2 years. And so we ought to do something for those premiums, ladies and gentlemen. Please give this bill a favorable report and choose the people you represent over profits. Thank you.
Thank you. Next, please.
Good afternoon. My name is Mukta Bain. I'm an intern for Maryland Citizen Health Initiative. We work to ensure all Marylanders can access quality, affordable health care. Madam Chair, Vice Madam Chair, and members of committee, thank you for opportunity to testify in support of this bill. Our Healthcare for All Coalition championed the establishment of Maryland's Prescription Drug Affordability Board in 2019 because too many Marylanders go through without medications they need due to the cost. EpiPens come up often when we talk with Marylanders around the state about this issue. While we believe the best solution is to allow the board to address affordability challenges through supply chain, we know this bill will provide immediate relief to many Marylanders who are struggling and urge a favorable report. Drugs don't work if people can't afford them. Thank you.
Thank you. Thank you for your testimony. So we're gonna open it up for questions now. Are there questions? Delegate Chisholm.
Thank you, Madam Chair. I just have a
You're
quick
welcome.
question. I think insulin's capped at $30, if I remember correctly. And I see in here that says $60 for a twin pack. And I know every case is a little bit different, but what a twin pack, what would that last on average?
Yeah, so that would be 2 injectors. The typical shelf life, if that's what you're getting at, is typically a year, although I'll say as personally, as an allergy mom, sometimes we've had them only have a shelf life of 8 months. The pack I just got is good for 14 months, but typically a year.
I guess you never really want to use it, but if you were to take the whole universe we were just talking about, 1 in 10, how long would 2 last the average family? Would it be?
Well, it's 1 year because the FDA is required just a 1-year expiration date. So this is the problem. Every year in a high deductible plan, you have to get rid of them because schools won't hold them. You're not allowed to use an expired EpiPen at schools. And so every year our folks are in line again at CVS paying more money for their Epis.
You're welcome. Delegate Hill.
Very much.
You're welcome.
I just want to make sure that your understanding is the same as mine. When the EpiPens first went up, they said it's the new injector. But at the same time, the price has risen for epinephrine alone in the office that we use without an injector. So that price has gone up. The expiration date is based, if you tell me if I'm correct, on stability tests that the manufacturer does, and stability tests only go out as far as the manufacturer wants to. So if they don't test it to see if it'll last 3 years.
Actually, ma'am,
Yeah.
not to interject on that.
Go
The
ahead.
FDA has made that decision and there's research, I'd be happy to follow up with you afterwards, that show they're effective for year 2 and year 3. The other thing is this pen hasn't changed. You know, people say price caps may harm innovation. The Epi hasn't changed in 37 years. It is still the only method for delivering epinephrine to us. We're hopeful for something else in the future, but right now this is it. Yeah.
Up on both, all over the
Yeah,
place.
yeah. I mean, it's the FDA approved it in 87. And if we can remember back to then, this is the only medicine that frankly hasn't changed. We're hoping for something, but the FDA has to act on that.
So it's not that the injector changed.
No, not at all, ma'am. There have been innovations. Kaleo makes a great product called AviQ. It actually talks to you. It's wonderful for children who are nervous or for first-time parents doing this. But the injection method is still the same. You take it, and you put it in the thigh and it works. So thank you, Delegate.
Okay. Delegate Kerr, followed by Lewis, followed by Woods.
Thank you, Madam Chair.
You're welcome.
In 2021, we passed a bill here, House Bill 14, that allows for medication dispensed in the original package to hold the manufacturer's date of expiration rather than the date 1 year from the date of dispensing. Are these EpiPens marked with a manufacturer's date of expiration?
I cannot speak to that.
If they are, then you have a right to have that medication at the school not expire automatically in a year. If it has an expiration date 2 years hence, that's the expiration date that now by law can be used.
Yeah, and so here's the thing though. I do this every day, all day. And there's 630,000 folks like me in this state, and this is not widely known, but this doesn't escape the fact that it has when they go to the pharmacy and the expiration date is 1 year, and Julie had mentioned, the delegate had mentioned, excuse me, that hers had been 8 months. You bring that into a school, there's no way they're going to let it stand for a day longer.
Only one answer. Only one person, but he can ask you a follow-up. You want to ask a follow-up, Delegate?
Yes, thank you, Madam Chair. Did you have something to add?
That would be wonderful. I wanted to explain what happens in the school setting because that matters for kids. We have to follow the doctor's order. It's good for a year according to pharmacy guidelines that me as a nurse am required to follow. In addition, I have to look at the expiration date on the pharmacy label and the expiration date on the EpiPen itself. I agree, EpiPen expiration dates, they're usually not more than a year. We look at the individual EpiPens. So we have to look at all three of those dates, whichever is soonest is the one that I am required to follow. That is the case in every school all across the state.
Yes.
Thank you. I think you have a case to change that. It's in law. It's in chapter 489 of the code. I'll be happy to print this out and get it to you.
Thank you.
Thank you. You're welcome. I have Delegate Lewis, followed by Woods.
Thank you, Madam Chair.
Thank you.
Thank you, Delegate Palakovic Carr, for this bill, and to your panel. Thank you. Everyone did well, including Ms. Bain. Well done. My question is this: there is unfavorable testimony on this bill, Delegate, from the League of Life and Health Insurers of Maryland, and I wonder if you've been able to talk with them and understand their opposition.
Thank you, Delegate Lewis, for the question. Yes, we did meet today and did talk through the bill in terms of the motivations and what their concerns are. We agreed that after the hearing today, we'd keep talking.
You're welcome, Delegate Woods.
Thank you, Madam Chair.
You're
I also want to thank Delegate Palakovic Carr and your panel for your testimony as an adult who just in the last year have been prescribed an EpiPen for things that I didn't know I was allergic to, hospitalized multiple times. It took years to realize what the challenge was. And so I literally just was prescribed an EpiPen. And the interesting thing, and I think it piggybacks on a lot of the questions that were heard today. As you and I and many in here probably know, and maybe some don't, a lot of times doctors will tell you, don't worry about the expiration date on your medication. Continue to use it. My question becomes and I hear that asked in a lot of ways here today, but my question becomes, what do we do to get the appropriate research, to get the appropriate information so that if EpiPens in fact last more than 8 months and a year, we put that into place so this will not compound the problems that we're currently having?
Madam Delegate, that's a FDA solution, and it's the only the FDA can act. And let me just share with you, we work with the FDA often on this. We passed a bill that labeled sesame recently. We did it in 2 years in Congress. They said it would take them 8 years to do it themselves. The FDA is not really known for speed. And so I think if we're waiting on the FDA, we're going to have a generation of families pay $700 or more for their EpiPens to continue on. There's been citizens petitions filed with the FDA and they've ignored them.
You're welcome. Any other questions? Seeing none, thank you very much.
Thank you, Madam Chair, and thank
Oh,
you,
yeah.
Delegate Woods, for letting me go ahead of you.
You're welcome. Swati Singh? BR Nan? Kristen Air? Actually, if I may, will you allow me, let me call in unfavorable because just to be fair, let me do that. If you can sit back again, I appreciate it. So we have, and thank you for being flexible. We have the League of Life and Health Insurers of Maryland, Matthew Celentano. Good afternoon. You wish they were back there with you, right?
Sure.
Yeah.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland in opposition to House Bill 939. I want to thank the sponsor for meeting with us earlier today to discuss our concerns, and we promise we will be happy to continue that conversation. We totally understand why the bill is introduced. I have a pretty severe bee allergy, so I am very aware of what's going on in this space. But I would never suggest that we don't want to have these life-saving drugs not be more affordable. But this approach will do nothing but give Big Pharma free rein to charge carriers whatever they want and increase everybody's premium. We shouldn't need to cap drug prices. Big Pharma should decrease the prices, especially for life-saving drugs like EpiPens. The problem is right there. It's all about the list price. We can talk about coupons, rebates, all of that. It's all based on the list prices. The drug was brought to the market, as one of the proponents said, about 40 years ago, and no new R&D has happened. The only thing that's happened is the price has absolutely skyrocketed. And that skyrocketing happened when it coincided with requirements for EpiPens to be at places like schools, summer camps. Chairman Peña-Melnick, thank you very much. You passed a bill in 2015 that required EpiPens in school and youth clinics or youth summer camps. That's really important. We want these things to be out there. But this is sort of an imperfect solution. Copay caps are an imperfect solution to high prescription costs. Decreasing the price of the drug for some insurance members means increasing premium for others. A cap doesn't lower the list price of the drug, so anybody else or everybody else has to pick up the difference. And this bill doesn't address why drugs are so expensive in the first place. You've heard us say it many, many times in this committee. About 10, 15 years ago, the percentage of your premium on prescription drugs was about 5%. It's now about 35%. That's because Big Pharma is unconscionably raising the prices on drugs that they shouldn't be. So we're unfavorable on this drug or on this bill. Thank you very much. I'm here to answer your question.
Delegate White Holland. You go first before I ask him a question.
Okay.
Go ahead.
Thank you, Madam Chair. And again, appreciate you being here, Matt, and as well as your commitment to continuing conversations with the bill sponsor. We've heard your testimony and elevating pharma as one of the key sectors that is driving these costs increase. And you've heard from the bill sponsor and learned of her outreach to our Prescription Drug Affordability Board. And so it then ultimately led to this bill. And so if it's not this, then what is the solution in which that you propose here?
Thank you for the question, Delegate. So I will say, some of you might know that in a former life, I worked in an advocacy space. And in that advocacy space, the development of going past coverage for all, one of the things we wanted to approach was the high price of drugs. And that sort of led to a prescription drug price gouging bill that was led by Attorney General Frosch, and then the development of the original Prescription Drug Affordability Board. And when we had those conversations with a variety of stakeholders, including NASHB and actually Kaiser Permanente, when I was wearing the white hat, so to say, there were three poster drugs that we came back to over and over and over. And they were insulin, Narcan, and EpiPens. And those three drugs were the poster drugs because they were developed for almost no money. The research and development had been done in the insulin's case 100 years ago, and the price just skyrocketed more and more and more. And there was no justification for those price caps. That led to the first in the nation Prescription Drug Affordability Board, using the examples, the case studies of those drugs. I was not involved in the discussions with the PDAB this summer, but the PDAB is the perfect vehicle for this kind of drug, which would have the most public benefit and address those unconscionable price drugs or price increases. And I would love to continue that discussion and make it a priority of that body.
Okay. Delegate Johnson.
Thank you, Madam Chair, and thank you for your testimony. With us capping insulin, has that caused premiums to increase?
That's really hard to say, Delegate Johnson, because when we did the state mandate cap on insulin, there was federal legislation, as you know, that came in behind it. And then also on top of that, with the American Rescue Plan and the prescription drug affordability portions of that bill, it led to pharma decreasing some of the prices on insulin. But they did it for a reason, and they did it to pad their pockets, because if there was a price increase on those particular drugs, they'd have to pay a penalty to the government. So there was a reduction in price in insulin, which led to them actually making more profit margin in that particular drug. So I can't really answer that question.
Absolutely.
And since they sold the EpiPens cheap in the past, and only until it was mandated that they were to have them in certain areas, did they start really raking people over the coals with the price. Right. What's your reasoning if we go back and cap it, that would cause premium increase?
So the problem
talked about with the insulin.
The problem with copay caps and why it's an imperfect solution is because if you tell the manufacturers that the consumer is only going to pay this amount of money, a cap on their premium or out of their pocket for the drug, there's no incentive for them to ever actually bargain or negotiate with the carriers to find the best cost. They just keep increasing because they know the insurers have to pay it. So yes, some of those consumers will see a lower cost spend on that particular drug, but because of what they'll jack up on the price in the other space, in that example, insulin, longer down the road, insulin's not a perfect solution because we just talked about why. But if you were to do this bill, they're just going to keep increasing the EpiPen, knowing that we can only charge $10 or in this case, $60 on a 2-pack for an EpiPen. They'll keep increasing it, and then the insurer has to pay for it, which in turn is going to get passed on in higher drug spend. That 35% is going to inflate, and it's going to be higher premiums for everybody.
Madam Chair.
You're welcome. Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
It feels like Groundhog Day and whack-a-mole. Whack-a-mole. So thank you, Mr. Celentano, for your testimony, for your thoughtful explanation of how drug prices are set. I just want to understand, you stated that the list price, which is set by the pharmaceutical manufacturers, is the problem.
Correct.
Is the enemy, the list price. And that the list price, they set it, but then insurance companies negotiate with the drug manufacturers.
Sure.
And the negotiation between the drug manufacturers and the pharmaceutical manufacturers, it's relatively transparent. It's a back and forth.
I don't necessarily say it would be the most transparent thing in the world, but yes, that's where we're getting into another, not my client, the pharmacy benefit managers, which is a middleman. The way that you have to basically look at it, and the way I try to explain it to, well, my kids couldn't care less, but when I try to explain it to my wife, a pharmacy benefit manager is basically just Costco for drugs, right? If we want to get back to the core base of it, they have capital, they buy a tremendous amount of the product at a reduced price, and then they pass it along to whoever wants to purchase that. In this case, the insurer is the purchaser.
Negotiated between the pharmaceutical manufacturer and the PBM.
Generally, carriers usually hire a PBM to negotiate their drugs for them.
And at this point, the only mechanism available to the state for having any impact on the list prices of drugs is the PDAB, the
one option. The state of Maryland actually has a PBM that they hire to negotiate the drug prices for all state employee benefit plans.
Absolutely.
So thank you for that explanation. So the state of Maryland has its own PBM.
They don't have their own PBM. They actually contract.
We contract, rather. Yeah. We have a contractual relationship with our PBM.
Correct.
that PBM can negotiate list prices for drugs made available under state employee health insurance plans.
That's correct.
Would a bill, is there a legislative fix that would allow the state's contractual PBM to set a price for EpiPens, and in doing so, establish a sort of downward pressure on pricing across the other parts of the drug pricing ecosystem?
Because the state of Maryland is a self-insured plan, they can do the benefit design any way they want to.
Everyone in Maryland on the state benefit plan. Never mind.
That is
Thank
an
you.
option.
Thank you, Madam Chair.
That is an option, Delegate
You're
Lewis.
welcome. Vice Chair Collison.
Thank you, Madam Chair. Thank you, Matt, for
Welcome.
being here. So just to follow up a little bit on Delegate Lewis's question, you heard about the reverse auction for the state trying to really put a competitive process in place to decrease the cost of drugs to the state. So we are working on that. I was puzzled, and I probably should have asked the sponsor. The response from the Prescription Drug Affordability Board was that it was unlikely that EpiPens would become a subject of upper payment limits because it doesn't cost the state enough. I'm puzzled by that statement because I'm assuming that they're paying a lot for it, which is being shifted down in copays to some degree.
I am puzzled as well, Madam Vice Chair.
Okay, and I'll have to follow up on that. And thank you.
Delegate Woods.
Thank you, Madam Chair. Thank you, Mr. Celentano. I need some clarification here.
I will do my
Another
best.
piece to the whole puzzle that I thought I heard you say that the PBM is like the Costco. When I think of Costco, I think of somebody whose goal is to lower a price. When I think of PBMs, I don't have the same thought. Can you please clarify that for me?
I was unaware that HB 939 was going to get into a briefing on the drug price chain, but I will do my best. The reason that insurers hire a PBM is to get the best price for purchasing, so they can add along to their beneficiaries. There is a lot of discussion around the value of PBM, and it's been in this committee for a very long time, as long as I've been around, and it keeps going over and over. But I will say that carriers are financially savvy operations and operators, and they would not use a PBM if they could get the price as low themselves. And you will see that some carriers were not using PBM services as recently as 15 years, but to combat the incredible skyrocketing of drug prices, PBMs have become a crucial tool to keep drug prices as low as possible. And we're still losing the war. Like there it is a crisis. If we're going to continue to talk about affordability and health insurance, we have to do something about prescription drug list prices. Health insurance is expensive because healthcare is really, really expensive. So if we don't continue to take measures to bend the cost of healthcare overall, we're going to continue to lose the war. Let's do it.
Thank you. Any other questions? I don't see any. So you singled me out for putting in the bill in 2015.
Thank you for putting in the bill.
And I also put in the bill to cap insulin, and
I
I
know you
also
did.
put in the bill to create a drug affordability board. And I did that with the support of everyone here because, you know, it takes a village. That being said, there's a reason why those bills are introduced by my colleagues and I, and that is because Congress is not working. And they're you know, pharma is not doing it. You know, they really have a lot of influence in Congress. So Maryland is pretty, I would say in a very humble way, we lead. We took the chance and put in that first bill, and we were challenged and sued. We didn't stop, right? With the help of all the advocates and everyone, we went on and put the Prescription Drug Affordability Board with Vinny and everyone else. That being said, the reason is because people here are hardly making it, right? There are people that cannot buy their food, and we heard this before. pay their rent or their mortgage, every month buy their medication, they're making these decisions. So what we try to do is to try to find a balance, right? Where it doesn't get you out of business, but where the sky won't fall and where we can find some balance. So if I know, I was looking at the fact that Delaware, Colorado, Illinois, New Jersey have actually dealt with this issue and have passed legislation to, cap out-of-pocket expenses. Can you do me a favor? And everyone that comes here, we give homework. Can you look at those states and get back to me, please, about what has happened in those states? What have they seen? So that we can make an intelligent decision.
Absolutely, Madam Chair.
Thank you so much. I appreciate it. And thank you for being so flexible as you sat there and you answered these questions. And not only that, Matt, thank you for working with a lot of our members on many other issues where you try to find compromise. We really enjoy working with you, okay?
Thank you very much. I appreciate you as well.
My pleasure. I would like to call the panel that I called before, and thank you for being patient. We try to be balanced here. Can't have it all be favorable, right? Have to be balanced. So can you give us your name?
Me?
Yes.
What?
Yes.
Oh, I'm Veer Singh Anand.
And I'm Dr. Swati Singh.
Okay, and who would like to get started, please?
Go first, babe.
Okay. Hello, I'm Veer Singh Anand. I'm 13 years old and I go to North Bethesda Middle School. I have a life-threatening nut allergy. When I was only 2 years old, an EpiPen saved my life. I was with my parents at a restaurant and the restaurant mixed up my order and gave me a dish with blended cashews in it. After just 2 bites, I started to anaphylax. Hives started to completely cover me and I started vomiting. My mother's an emergency physician and realized right away what was happening. So she administered the EpiPen and called 911. That initial dose of epinephrine bought me enough time to get to the hospital and receive life-saving treatment. When I think about that episode, I think about how fortunate I am that my mother is a physician, that we have emergency services, that we have good hospitals, and that my parents were able to afford an EpiPen, which at the time cost them $500. However, some people are not as fortunate. My hope is that with this bill's passage, other kids who have severe nut allergies don't have to worry about whether the cost of this life-saving drug is too expensive for their parents to afford, and if this could one day cost them their life. Thank you for giving me this opportunity, and thank you for letting me skip geometry class.
I love it. I love it. Good job.
I
Next,
should have gone
please.
after him, but before him. So I'm Dr. Swati Singh. I'm a board certified emergency physician, and I've been working in Prince George's County for the last 10 years. And I'm really excited to be able to talk to you guys today about capping the cost of this medication. It affects me personally as a mom of a child who has life-threatening nut allergies, but also as an emergency physician who's taking care of many patients who come to my ER in anaphylaxis who need epinephrine, immediate administration of epinephrine. And it's important to know, as mentioned by some of the previous testimony, that it's prohibitively expensive to buy, even though it's inexpensive to make. Because of its expense, it's out of reach to my patient population in Prince George's County that I can speak to personally. It expires frequently. It's a lay-ball medication, which wasn't mentioned. Sometimes if it gets exposed to extreme heat or cold, like you forgot to leave it, you left it in your car, that can make the medication less effective and require you to replace it. You might need multiple doses of it in various places so that you always have it in reach. So that again makes it very costly for patients. And it needs to be administered within 30 minutes of a suspected anaphylactic reaction. If you take it too late and your reaction becomes severe, it doesn't matter how much epi you get, it will not make a difference. And all 3 points remind me of many patients I've taken care of in the past, but my most severe case, which breaks my heart to this day, was an 18-year-old kid who came in to the ED in anaphylactic shock. And as I was taking his clothes off and exposing his body in order to resuscitate him, I noted that he looked like the picture of health from the outside. He looked like my anatomy textbooks, but he had this one life-threatening condition. And he arrived brain dead in anaphylactic shock because it was too late. It was too late. And when I talked to his mom, she said the last thing he said to him, or to her, was, "I can't breathe," before he collapsed. And it was because he didn't have an EpiPen readily available because it was too expensive. And that day, the paramedics couldn't get to him in time. And he got to me too late. And needless to say, it was his death was a loss of life that was preventable because of lack of access to an affordable medication that could save him. Thank you very much.
Wow, thank you for sharing that story. That's really sad. And thank you for the work you do. Next, please.
Hi, my name is Kristen Ayers, and I'm the parent of 2 children with multiple life-threatening and severe food allergies. We've got peanut, tree nut, wheat, egg, and now finfish. When my children were very young, they were diagnosed, and it's really hard to explain to a 2-year-old that if they grab a brownie off the table, it could kill them. You know, we're out at a public setting. And one of the things that I learned to do was make sure we always had epinephrine in reach. And it breaks my heart to hear the stories today because we've got an EpiPen at home in a place that can't be moved. I have 2 in my purse. My children have 1 in each of their backpacks. The school nurse has them. When they go to camp, they keep them overnight. So there's no chance that in the exchange from the morning and the afternoon that one is lost. Take them to a grandparents' house. They have the EpiPen in a certain place. You need to have access to that device within seconds. You know, sometimes a few minutes is too much. The fact that you have parents who can't afford to give 1 to the school nurse and 1 to their child, so they have to split the dose. I can't imagine the emotional stress of that decision. And I hear someone telling me that there's a bigger problem that we need to solve. And meanwhile, we have kids who don't have access to the medication they need. Come on. Let's get this done. Don't delay this, please. There are too many children out there with food allergies that are vulnerable. We need to act now.
Thank you for coming today and sharing your story. We really appreciate it. And I hope your kids stay well.
Thank you.
You're welcome. Are there any questions for this panel? Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
Thank all of you for your testimony. It means a lot to have you here with your lived experience. We may forget the analytical, details from some testimony, but we won't forget your stories. Young man, you're lucky to get out of geometry today. My question is about, I think for the mom with the pearls, please forgive me for not remembering your name. What you're able to purchase multiple packs of EpiPens. Has that expense been a hardship for your family? Have you been able to manage it, or is it difficult?
Well, we have the ability to do it.
Closer.
So we have the ability to do it. It's that simple.
Yeah.
Not everyone can do that.
That's right.
And that's the problem. So, I can't imagine what it's like to know that if you make a mistake, if you forget the EpiPen, it happens to us all the time. That's why we have a backup. And you're, 3 hours into your drive, you're visiting a relative and it's a holiday. So you might not be able to get one, right? And even if you could, you might not be able to afford it. So you have to play Russian roulette with your child's life. And what kind of example are you setting with your child? Oh, we're just going to risk it. You don't want to do that.
Understood. Thank you so much. Thank you, Madam Chair.
You're welcome. Delegate Rosenberg.
If I may, you're missing your geometry class, so you can get a little political science. And that is, in this room, we need to count to, what is it, Madam Chair, 14?
Majority.
We need to count to a majority. And so hopefully for your sake, your testimony helps us get to that, count to that number, but that's how things work here.
And for us, here's 12. And you couldn't tell from someone they had to take geometry twice in high school. The only class I ever failed, geometry. Anyway, thank you, Delegate Taveras.
Yeah, thank you, Madam Chair.
I have never disclosed that in my life.
Delegate Taveras. Yeah.
Go ahead, Delegate Taveras.
Yeah, I'm learning. Thank you, Madam Chair. I'm learning. Geometry is fun. So my question to Ms. Singh, where do you practice? In what hospital?
I practice at Cap Region Medical Center. It used to be called PG. We just moved to a new location in Largo. I'm a University of Maryland associated physician.
Thank you.
She knows it well. She represents Prince George's.
Oh.
Thank you, and thank you for your service. I don't see any other questions. So thank you for being patient with us. We really appreciate it. And actually, this concludes the bill hearing on House Bill 939. Thank you so much for being with us today.
Thank you.
And now we're really going to get to Delegate Woods. House Bill 1120. And Michelle Everly will be with you after this bill. Thank you. Delegate Woods, will you be so kind? I believe you have Judith Chagrin. Okay, and Sika. Okay, how about Judith?
Very capable.
Wonderful.
Very much.
And she will do a very good job.
And I have no doubt about that whatsoever.
Go ahead. Good afternoon.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and to this illustrious Health and Government Operations Committee, to which I must share that I am humbly honored to be a part of. For the record, I am Delegate Jamila Woods, and I am here to solicit your favorable report for House Bill 1120, State Board of Social Work Examiners, Continuing Education Programs, Approval of Authorized Sponsors. This bill requires the Board of Social Work Examiners, otherwise referred to as the BSWE in Maryland, to establish a process to review and approve a person seeking to become an authorized sponsor of continuing education programs for social workers seeking to renew their licenses. Social work continuing education units represent the foundation of professional growth and development, assuring that social workers have updated and accurate information, including relevant shifts of knowledge of information, aligning with emerging best practices for the diverse populations and circumstances that they address. Master level social workers in Maryland are required to receive 40 continuing education units every 2 years to maintain their licenses. As a licensed social worker, I too fall into this categorical requirement. There are two categories, categories 1 and categories 2. Category 1 requires 20 CEUs, and this category 1 has a cost to the majority, if not all. There's an associated cost for achieving the CEUs. Previously, there was a process for individuals to apply to be approved by the BSWE to become a board authorized continuing education sponsor. On January 1st, 2021, the BSWE stopped accepting new applications, and in December 2023, regulations were finalized that completely eliminated any process or responsibility for the BSWE to approve new providers. The aforementioned process in the past ensured quality control and was affordable for potential sponsors because once the potential sponsors were appropriately vetted, they could offer workshops without paying an additional fee for every workshop. This method also provided an opportunity for new continuing education providers to be vetted and to provide their expertise and workshop offerings. Once an agency receives the sponsorship approval, they're able to sponsor workshops at no additional cost. There are currently 3 positions allocated at the BSWE to continuing education units. While it is possible for agencies to seek approval for national organizations, the cost is often exorbitant and the approval must be established for each individual workshop that's offered. Again, and especially now, with the current economic challenges and barriers impacting so many, seeking these national approvals is both lengthy and costly and can adversely impact situations where social workers need to receive the required training. But these national approvals are also not guaranteed to be granted in time. The fees from the ASWB and NASW are hundreds of dollars for each workshop offered, and additional fees, which Judith Shagrin is probably happy to address if you ask her those questions, including an application fee and other fees. The Maryland BSWE controls the continuing education requirements, including required and approved topics for continuing education, and therefore are best suited to know the training needs of Maryland social workers. With this information, I would ask that you favorably pass HB 1120. Thank you.
Thank you, Delegate, for your testimony. Good afternoon, ma'am. How are you?
Good, good. Thank you.
You're
Good
welcome.
afternoon. My name is Judith Shagrin. I just want to say what she said, but here I am. We have a minimum of 40 hours of CEUs every other year. As long as I can remember, that was the responsibility of the Board of Social Work Examiners to approve providers for continuing education. We're simply looking to restore that responsibility. I had a really satisfying social work career in public child welfare at the Baltimore County Department of Social Services, where we were able to offer free CEUs to our staff as an employee benefit. By being an approved provider, we were able to offer our employees training and education specific to their unique responsibilities in child welfare. As of January of 21, no entity can be approved as a CEU sponsor, and anyone who would like to be is now forced to turn to national organizations, which is a costly and a lengthy process. Closing the door to potential providers after January of 21 simply makes no sense, and it's short-sighted. Times change, practices change, requirements change. We need a facile and affordable approval process for new providers. New requirements were added to the social work licensing for continuing ed. I think it was last year or the year before. We won't be able to approve new providers to offer that training. Forcing social workers to rely on an increasingly outdated list of providers just doesn't make sense. In short, HB 1122 is a no-brainer bill, one that will support the social work profession, providing services to vulnerable Marylanders, and moreover, will be able to help us to address workforce shortages because state agencies like the Department of Social Services can be approved to provide CEUs as a free benefit to their staff. Thank you.
Thank you for being with us today. I'm going to open it up for questions now. Are there questions for this panel? Delegate Lewis.
Thank you, Madam
My
Chair.
pleasure.
Thank you, Delegate Woods, for this bill and for trying to help us solve our social work profession needs. I noticed in the testimony that there's opposition from the Maryland Board of Social Work, and I was wondering how, if you could talk about how you hope to resolve that opposition. Thank you.
Yes, thank you, Delegate Lewis. The issues, if you read in the paper, that the Maryland Board of Social Work Examiners articulated included limited resources and revised board priorities. We are welcoming a conversation because, needless to say, having limited resources does not mean that the service is not necessary. And so we're looking at ways that we can help to alleviate the lack of staff, if you will, and lack of time to address those particular issues. Does that answer your question?
Board to answer their concerns.
Yes.
Okay.
And if you have any further information, we'd love for you to ask
my panelists.
Yes,
also.
ma'am. Thank you. Thank you, Madam Chair.
You're welcome. Any other questions? Seeing none, thank you so much for your testimony and for your work on this. We do have an unfavorable, Karen Richards. Are you here? Good afternoon, ma'am. How are you? And will you bring the virtual person up as well, please? Thank you. You
Good
can get
afternoon.
started.
Thank you, Madam Chair,
You're
Vice
welcome.
Chair, and committee members. I am Karen Richards, and I am the new Executive Director of BSWE. And I am here to testify on behalf of the board in opposition of Bill 1120. The board has already submitted written testimony which details the process we underwent to remove the sponsor program. The regulation change did become effective on December 11th, 2023. So why did the board make this difficult decision? In short, approving continuing education sponsors is labor intensive. ASWB sent you an informational letter detailing their process for their ACE program. I had the opportunity to meet with the director of the ACE program, and I want to share she has 4 full-time staff members dedicated to approving sponsors and CE courses for social workers. Our board has 2 full-time staff members in our continuing education unit. We do have 1 other vacancy, which is a contractual position, which was added a year ago. What do our staff members in our continuing education unit do? Well, they do more than just approve sponsors and courses. They answer questions from licensees about how many CEs they need. They coordinate and review CE audits. And like all public servants, they have other duties as needed. If the board gets back into the business of improving sponsors, we will need additional staff and resources indeed. But why do that when there are national organizations such as ASWB and NASW who are already in the provider approval business? Licensees can currently go to our website and they can find that we already have 415 approved sponsors within the state. Our board has multiple pressing issues at this time. And we feel that approving CE sponsors is not one of them right now. So we are asking for an unfavorable report on House Bill 1120.
Thank you for your testimony. I'm going to open it up for questions now. Are there questions? Delegate Lewis, followed by Johnson.
Thank you so much, Madam
You're
Chair.
welcome.
I've asked more questions today than I have in 6 years. Because we have.
You might owe some cookies. I heard there's some cookies in the back.
But thank you so much for your testimony. And I do understand the constraints and challenges that the Board of Social Work is facing and that the profession is facing in general. But I'm curious, you mentioned that there were how many certified sponsors in the state, 100 some?
Well, so far, so from when we were in the business of approving sponsors, and our staff worked diligently with provisional sponsors before this was going to become effective to make sure that they were board approved. So we have a list of 415, which includes a lot of the state agencies within the state already.
Thank you.
And they are approved.
And those 415 or so, do they represent the population of folks needing services? Are they geographically distributed in an equitable way? Do they have cultural competencies? Can we expect a high standard from those 400?
So before I came here, I was with the Department of Juvenile Services for 10 years. We were a board approved sponsor. We provided trainings that were represented the needs of our social workers in our agency at that time. We were constantly looking at what trainings we were offered. So yes.
Juvenile services. So what about, that's one, what about the other 414? They have the same breadth of standards and competencies
Yes,
and
of course. And
cultural
many
and
of them-
geographic
many of
representation?
them are national organizations. All the hospitals throughout the state are board approved sponsors. So
Very helpful.
yes, it
Help.
definitely represents the diversity of the social workers in the state. Yeah.
Thank you so much, Madam Chair.
You're welcome. Delegate Johnson.
Thank you, Madam Chair, and thanks
You're
for coming
welcome.
to testify. So when you performed this function, did it work? And notwithstanding the workload, with our shortage, if you did this function again, would it help?
Did it work? It unfortunately pulled staff away from the other duties. A very time-consuming one is the audits. So licensed social workers within the state of Maryland, they are subject to continuing education audits. So randomly, your license could get pulled, and then we're gonna look at you and see if you did meet your 40 CE credits. Again, very labor intensive to assure that once that the licensee.
Yeah,
once
the
they
question
complete-
was, when you did it work? And if you did this function again, would it help with our staffing shortages?
Would it help?
Yes.
Did it work? Yes.
Okay.
Would it help? I'm not sure that it's necessary now because there are other mechanisms to approve sponsors. This isn't really about our licensees. This is a little bit more about providers who want to do the trainings.
Right.
Right? So, would it help? What would help more would be to fill our vacancies in our other units, like our licensing unit, our compliance unit. We have other issues that we need staff for right now. So, getting back into the provider approval business, I don't think is a priority of our board right now.
Thank you, Madam Chair.
Thank you. Are there any other questions? Delegate Bagno.
Thank you, Madam Chair.
You're welcome.
And thank you for being here today. I'm feeling a little bit like Groundhog Day, given that we've been working, on some issues with the board and temporary licensure and the national exams and and we have an entire work group on social workers. But I think my concern is that in all of these discussions, we start with no and end with no. And my question is, how do we get to yes in any of these discussions? And have you talked to the bill sponsor? Have you met? Have you had a conversation about how we can get to yes?
So I'm 3 weeks in as the executive director. I do think there are a lot of other issues facing our board that we would like to have more thorough discussions with to get to yes. I think on this issue, since we had several years and the regulation change was finalized at the end of December 2023, this is an issue that we would prefer not to have to revisit so that we can better address the other issues facing the board.
Delegate Martinez.
Thank you, Madam Chair. Could you help the committee just understand a little bit more the impact of the cost factor for social workers who are adversely impacted when other organizations are providing these CEU trainings or required CEU trainings?
So is your question in reference to how much CE trainings for licensees cost?
Yes.
Okay, so there are, a range of costs on CE trainings. I'm not the expert in that. I know in my 30 years of being a social worker, I've been able to find plenty that were free to low cost. I also was very fortunate to work in an agency that recognized the importance of my license and would reimburse for some of my CE trainings. I think that's a more important issue for us to be looking at. Again, this bill addresses providers. This is about getting providers to be able to provide, to do trainings within our state. This isn't really about the licensees, okay? And ASWB, they do have a program where they will approve an individual course for a sponsor. It's $125.
if a provider wants to do just an individual course within the state, they can go to ASWB and do the individual program. Again, I think that what we need to kind of recognize again is that this bill really is about CE providers and not so much about social worker licensees. You know, there's, you know, and plus, if we look at national organizations like NASW, or you even look at, so a licensee could take a training from a university that is accredited by the Council on Social Work Education. And we know that a lot of the universities now, what do they have? They have online programs, right? So, you know, young social workers, they want to do an online program. So they could go to a university, take a course through a university online, and, you know, it would be an approved CE through our board. So I do think there are a lot of options for licensees to get trainings. I hope that answered your question. I kind of felt like maybe I went a little off.
Delegate Olston, followed by Vice Chair Collison.
Thank you, Madam Chair.
You're welcome.
So I just read the bill and I don't see it the same way you do. You keep saying it's about providers wanting to get the approval, but as a professional, when you need continuing education, you depend on your board to vet people to make sure that it is appropriate. Would you not agree?
Correct.
Okay.
Correct.
So as the board, and what I'm hearing is you all don't find it as a priority or don't want to do it. I'm not 100% sure which one, but if you all don't want to do it, would it be better if we just gave this authority to the Department of Health?
No. So our board does find good quality continuing education is a priority. And our staff does review many of the trainings that licensees do. Again, we partner with national organizations like ASWB and NASW because we trust in what they do to approve. So if a training comes through and it's by a ASWB board approved sponsor, we know because we know what their process is. So no, it's not that we don't think that having quality CEs is not a priority. What we don't have the staff and resources to do is to do the sponsorship program. This is why in 2019, we started the process to get out of that business.
Okay. Vice Chair Collison.
Thank you, Madam Chair. And thank you for your patience in responding to the questions. So I hear two things. I hear one thing, and then I do have a question. I hear that in order to make sure that licensees have the continuing education hours that they need, there are sufficient third-party providers. And so we don't need those providers. So I'm wondering though, last year in the discussion about, you know, activities and the licensing process, et cetera, one of the things that came out was this need for lack of a better term, like a mentor through the first year of service. And in some cases they were paid, in some cases they weren't paid. Would this sponsorship program that the delegate is talking about identify those who could become these like mentors?
It's not my understanding that the sponsorship program would do that. My understanding the sponsorship bill is about providing continuing education trainings, not mentoring.
So it would be just your interpretation is that the only thing these folks are asking for is to be able to teach one course.
To become board approved, board approved sponsors to private courses.
Okay, thank you.
Delegate Gazzoni.
Thank you, Madam Chair.
You're welcome.
So I'm trying to wrap my head around all this. The list of 415, which I just glanced at, so it seems quite comprehensive to me. And I'm assuming that's sort of an ongoing list, that there's not going to be like in 5 years, we need to look at this list again, that those are pretty much organizations that are continually going to be running.
Correct.
Okay. Okay.
What we would like our staff to be able to do is to be able to check in with those sponsors every 5 years and see what trainings have you been offering? What is the quality of them? That's just why we kind of wanted to back out of the front end of approving them so that we can pay more attention to the already approved ones.
Sure. Can one more? Thank you. So given that, what this, just make sure I understand the bill, what it seems to be saying is that there needs to be a pathway, just one pathway, sort of outside of the national accreditations and presumably outside of these 415 organizations for someone to get in. Is that correct?
Correct.
Okay. Okay, can I do one more?
Yes.
Thank you so much.
It's okay. You don't ask many questions often.
I'm really trying to understand the process here.
Yeah.
So there would be nothing precluding anyone who wants to, like someone who's moving into the consulting business or whatever, from working with any one of the 415 organizations that are already on your list, from working with them to get a course that they would be able to put underneath?
Yeah.
Okay. Thank you very much.
You're welcome. Any other questions? All right. Thank you so much for being patient. I know you want to fly. Okay. Thank you for being patient and being with us, and welcome to your new position. You're welcome. Good afternoon. Do you want to unmute yourself?
Yes, thank you. That would be very helpful. I really appreciate
okay.
it. Sorry about that. Good
How are you?
afternoon. I'm doing well. How is everyone?
We are hanging in there.
Good, good,
A couple
good.
more bills to go.
I will try to not be before you very long. Good afternoon again, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. I am Dion Brown Bushrod. I'm the Director of Education Programs for the Association of Social Work Boards, ASWB. You have our detailed information, and I'd like to just share a few highlights with you. ASWB was formed more than 40 years ago to relieve state burdens associated with the administration of their social work regulatory mandate. As an ASWB member, the BSWE has access to continuing education services offered through ASWB approved continuing education program, ACE. Continuing education providers who apply for ACE approval must be able to demonstrate that they meet or exceed standards to ensure high quality programming and to satisfy CE requirements for licensees as dictated by the social work regulatory boards across the United States and Canada. ACE is also a joint accreditation interprofessional continuing education partner, and that extends the social work licensee's reach into additional collaborative healthcare education learning activities. ACE has an efficient online system that streamlines providers' applications, approvals, renewals, and audits, and our staff is comprised of licensed social workers. With ACE approval, continuing education businesses, regardless of scale or type, individual, large, commercial, public, private, these businesses can grow their continuing education solutions without burdening licensing fees. Thank you so much for the opportunity to share this information.
Great timing there. And thank you for being patient as we went through all the questions, okay? And everyone else is waiting for the 2 bills that we have left. We are very grateful. Thank you for your patience. Are there any questions for this witness? Seeing none, you have a blessed evening, okay? Thank you for being with us. And this actually concludes the bill hearing on House Bill 1120. Now we're going to go to House Bill 953. And if I may have Michelle Everly, Allison Taylor, Stephanie Clapper, Mutrat Bain will be great, and Jamie Sexton. If you could just come up, we're just gonna do it all. And thank you for your patience. So, I don't have many bills, and I try not to. But I have this one as well today. And let me tell you why I put it in. I want to thank the vice chair and the committee for allowing me to present this bill for you, House Bill 953. So over 90,000 Maryland adults ages 18 to 34 were uninsured in 2020. And our goal on this committee, we started with Obamacare, right? In 2011, we expanded Medicaid. We actually, did the reinsurance program. We did the subsidies for young adults, the pilot. We did the check the box when we do the taxes. And our uninsured rate back then when we started, Michelle, correct me if I'm wrong, was 14% of the population. At that time, we had about 6 million. That was about a little over 756,000 people for someone who failed geometry, but that is what the number is. And then what happened, we reduced it all the way from 14% to where it is today, 6%. So we have left 350,000 or so people that are uninsured in our state. Now, this program in 2021, what the committee did was that we passed a bill that required the Maryland Health Benefit Exchange to establish a state-based young adult health insurance subsidy pilot program, and that was Delegate Kerr. Thank you very much for your leadership. This pilot program reduces what young adults pay for health benefit plan in the individual health insurance market. While residents who meet age and income requirement are eligible to enroll in the program, additional payment parameters for the program were implemented. As a result, this is what happened. The exchange limits the $20 million in annual subsidy to be dispersed among eligible residents for each fiscal year beginning in 2022 and lasting to 2026. So since in its enactment in 2021, the pilot program has served, how many people? More than 50,000 qualified residents, right? These young adults. And that number is only increasing. Income groups between 133% and 400% below the federal poverty level received financial aid to support them and to help them buy the insurance. However, the amount of financial aid enrollees receive vary greatly on their income, family size, and zip code. So we could do better for our residents. So this is why you have this bill. Reallocating these unspent funds that the exchange has to benefit this young adult subsidy program will make a big difference. So Michelle is going to tell you, Michelle Everly, why we have this bill and why we need to do this to be able to optimize the available resources and to increase the number. Because at the end of the day, it increases the pool. They're very healthy. They don't have to pay much because they're healthy, and we get to cover many people. Was that okay, Michelle?
That was perfect. Ditto.
Go ahead.
Thank you, Madam Chair, Madam Vice Chair, and committee members. I am pleased to be here today to present this bill and offer or ask for your favorable finding for this bill. This is really a technical correction to this bill. We have a 4-year pilot program that was legislatively approved, that allocates $20 million per year of the reinsurance fund, not general funds, reinsurance fund, to the young adult subsidy program. The first 2 years, we underspent that fund by about $6 million each year. This year, we are projected to overspend it by $2.2 million. The reason why we've had such tremendous success this year, one, our direct outreach and marketing, but two, and most importantly, the Medicaid public health emergency unwind. So we've seen a lot of people that were in Medicaid getting free health coverage, now moving into the commercial market. And even though the average state subsidy is about $38, to some people, that's the make or break for them getting insurance. We saw a 41% increase in age 18 to 34, this open enrollment period.
that equates to 1/3 of our population in the individual marketplace. Those are young, healthy people. So that really helps the pool. So again, what the technical change is, it allows us to use that $20 million, which is in the statute, plus any unspent funds from previous years. That's it. No new money, no financial impact. So with that, again, we ask for your favorable report.
Thank you very much. Who will be next, please?
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. I'll say I love all fields of math, not just geometry. And based on what I heard from my dear friend, Ms. Eberly, it sounds like if they just had a $2.2 million overrun, the hope would be that there'd be enough to address other overruns through the sunset of this program. And certainly we hope all Kaiser members who are eligible would be able to benefit from this. So urge a favorable report.
And thank you so much, both of you, for working with our committee on many issues and helping our members. Next, please. You don't have to touch it.
Yeah.
The light is red already, just keep it.
Sorry.
It's okay, everyone does that.
Good afternoon. My name is Mukta Bain. I'm a doctoral student at Morgan State University, pursuing my health policy and leadership degree, and an intern for Maryland Healthcare for All Coalition. Thank you, Chair Penny Malik, and the committee members for allowing me to testify in the support of this bill. As a young adult and on behalf of more than 400 faith, business, labor, community, and health care groups across state that make up our coalition, I thank you for creating this very successful young adult subsidy program, and I urge you to support this bill. During the height of the pandemic, I was covered through Medicaid, but I was unsure if I would still have the coverage because I was hired as a contact tracer, and as a contract position, we were not, we didn't have health insurance. Because of the COVID emergency fund, I did have Medicaid, and did have Medicaid, but I wasn't sure for how long, so I was stressed and scared. I to pay for my therapy session or my medication. While searching on Maryland Medicaid Connection, I noticed either the premium or the deductible was too high. I was in a position where I had to choose between paying for my rent or for my medication. Thankfully, I was to find a new position that provided health coverage, but not everyone is as lucky as me. That's why this program is very important. Young adult age 18 to 34 are the highest uninsured age group in Maryland, and often for employers who not offer coverage. Thank you to our awesome leaders in Maryland who have started and supported this subsidy program to make health coverage affordable for eligible young adults. The program is widely successful, and these technical changes are needed so that all eligible candidates for the subsidies can receive them and get the coverage they need. Let Maryland be an example for other states to follow our lead, and urge you to support this bill. Thank you for your leadership.
Thank you for your testimony today. Next, please.
Thank you, Madam Chair, Madam Vice Chair, members of the committee, and thank you, Madam Chair, for introducing this vital piece of legislation. My name is Jamie Sexton. I'm the Director of Legislative and Regulatory Policy for the Maryland Insurance Administration. Commissioner Brain passes on her apologies for not being able to be here, but I'm grateful for the opportunity to share the MIA's strong support for this vital piece of legislation. I don't know that I can add much more value beyond the very eloquent points that have already been made on this bill, but I do want to emphasize the fact that this legislation is critically important to ensuring that our risk pool is as healthy as possible. The program has been very successful, as Michelle emphasized. It has increased due to the Medicaid unwind, and as I mentioned, is critical to bringing those young people into our pool to ensure its health. As was mentioned, we are looking at having an overspend of about $22.5 million this year. However, there's just shy of about $13 million in unspent funding that makes sense to be able to tap into. The continuance of this program has already been baked into actuarial analysis of the health of our reinsurance program. So it's going to have no impact on our reinsurance program as it stands. It's just allowing us to keep these young people in the program that, again, really contribute to the health of our risk pool. So thank you. We ask for a favorable report on this piece of legislation.
And thank you for being here with us, and thank Commissioner Lorraine for all her hard work. She's always available for us. I'm going to open it up for questions now from the committee. Are there any questions? Vice Chair Collison.
Well, thank you, Madam Chair. So two questions real quick. Did I hear 50,000? Is that right? 50,000 young adults have taken advantage?
We had a 41% increase this year, and that number, well, we have 214,000. Let's do the math. 214,000 total enrollees. About 30% of those are between 18 and 34.
So about 70. So we're going to let Allison do the math, but that's okay.
Over 50,000, say the geometry person. Go ahead.
And I just want to make sure that I understand. So the utilized funds were designated specifically for young adult. They're not coming from another funding source. So it's simply what was already funded and but not used and can move into the next year under this bill. Is that correct?
Absolutely. The way the bill was written, it capped it at $20 million a year. And the first 2 years, we didn't come near that, but we didn't allow for us to roll over that fund. But it's an $80 million over the 4-year period.
Thank you very much.
You're welcome, Delegate Hill.
Thank you.
You're
And
welcome.
actually, the vice chair's questions helped a lot. So without this bill, you said there's a overspend. So that means that there are people who've applied and we've promised them subsidies and we're not going to be able to pay them not because the money's not there, but because we're not allowed to spend the money. What happens without this bill?
That's correct. And the Board of Trustees, the Exchange Board of Trustees, as we set up the program, if there was not enough money or if we were going to run out of money, then they would cap the program. So they would stop offering coverage to folks. And as we have special enrollments throughout the year, because we know people may not stay in the full year, but we would cap the program and just stop offering it.
Thank you. Any other questions or concerns? Seeing none, thank you very much for your hard work, okay? Really appreciate it on everything you do. And next we have Stephanie Clapper. Stephanie Clapper here. I don't see her. Okay, thank you very much. This actually concludes the bill hearing on House Bill 953. Next, we have House Bill 1085, Delegate Collison, Maryland Insurance Administration, Mental Health Parity and Addiction, Equity Reporting Requirements, Revision and Sunset Repeal. Delegate Collison, I believe that your sponsor panel is Henry Harbin, David Cooney, and Mary. Is she here? Okay, great. I stopped to look for you. How are you? And you can have a seat and get started.
Thank you, Madam Chair. Thank you, members of the committee, for the opportunity to present 1085 to you today. We've been looking at mental health parity for a number of years, and we're looking for ways to really resolve any issues in terms of doing analyses, in terms of the accountability of carriers, and we want to improve our processes. That's really what this bill is about. It addresses the need for greater accountability by health insurance carriers by creating more specific reporting requirements and analysis of relating to the compliance of the Federal Health Parity Addiction Equity Act, which some people call MAHIA, but that's harder to say. And this bill also establishes remedies and penalties that the Maryland Insurance Commissioner may use to enforce compliance. You know, historically, and we've talked about this as well, the insurance coverage for services and treatment of mental health and addiction were often limited by carriers. And in terms of reimbursement, provider networks, allowance of time and treatment, and authorization. Maryland was an early leader in requiring coverage of mental health treatment in the 1990s, but permitted some differences even then. In 2008, the federal government passed that Mejia bill to assure that insurance coverage of these illnesses was comparable to medical surgical coverage, right? So equality, equity between mental health and substance abuse and medical surgical coverage. The federal legislation addressed both quantitative, things you can measure, and non-quantitative treatment limitations, in addition to cost sharing. Qualitative limitations include like the number of visits you are allowed to the mental health provider. Non-quantitative treatment limitations, or NQTLs, and I'm going to try to say that as clearly as I can over time, include things like reimbursement to providers, utilization review for medical necessity, pharmacy formularies, and other aspects of plan design that are not numerically measured. Maryland's law mandating coverage of mental health treatment has been revised over the years, even since I have been here, to further strengthen the protections for consumers. The most significant changes occurred in 2010, when Maryland law was revised to comply with the Mejia statute, and in 2015, when the law was further revised to codify the requirements of the federal final rules under the Parity Act. In 2020, this General Assembly passed a law codified in the insurance article, which establishes Maryland as a national leader in the enforcement by requiring carriers to submit reports of detailed analysis of 14 categories of NQTLs. Now, so let's say 14 categories in each of the plans that an insurance carrier has. And you'll recall that I've said Care First has 100 plans. So they would be reporting in 14 different categories on all 100 plans. The requirements on carriers based on the federal and state law are really comprehensive. Each carrier has multiple plans, as we just talked to, and I spoke about, and they have to prepare each year. So the federal law says they have to gather this data and analyze this data every single year. And the MIA has been collecting these analyses, but they are not complete for any carrier. They've been collecting the data, but they're not complete. Again, it's a process that is very labor intensive and extensive. Now, for the MIA, the time it takes to review these reports is about 20 to 40 hours on one of these NQTLs. If you want to do a comprehensive, meaningful analysis, that's how much it takes. Then when they don't have all the information there, you have to spend the time to follow up. And that can sometimes require 30 to 50 additional hours on each one of those NQTLs. If MIA completed the review and the process, the follow-up process in the way they're currently required to do, they would do nothing else. MIA, all the other work of the MIA would stop, including responding to complaints for consumers. With this bill, what the MIA is requesting is a revision to the process that will allow them to accomplish the goals of the Federal Act by doing an in-depth analysis on a defined number of NQTLs, and specifically looking at those that have the most impact on the services that people receive, and that it would give the commissioner the authority to choose which ones of those NQTLs they wanted to look at. Right now, MIA has the authority to go to any carrier and say, I want to see your analysis of this NQTL. They can do that anytime, right? But under federal law, the carriers don't have to actually give MIA the thousands of analyses that they have. They just have to have them available if they're asked. The bill would not remove any authority that MIA currently has in terms of monitoring, reviewing, and holding the carriers accountable. But what it does do is reduce the overall workload on MIA by decreasing the number of reports that the MIA is required to review in each reporting period. More importantly, it allows them to do more complete analysis of the work of each company with more time to follow up with deficiencies. This process will increase the intentional and deliberative accountability for assuring mental health services. This is about improving the outcomes, not just about gathering data, but make sure that we are using the data to improve the outcomes. It will ensure that the review is in-depth and bring the health plans into compliance with the law, which should lead to increased access to care by consumers. You're going to hear another bill right after this one, which seeks to improve compliance to the law with similar elements. We're still working together to try to get to yes, Delegate Bagnall, on how to make this law work in the best way possible, but to make sure that insurance carriers are held accountable in a very deliberative way and that we can actually make progress in this. I've invited Dr. Henry Harbin to come and be on my panel today because he's a national expert on this, on the NQTLs and the analysis. And he has a 2-page resume. So I'm not going to read his whole resume, but he actually co-wrote 6-step parity compliance guide for NQTLs. He informs the Department of Labor and HHS on the sub-regulatory process of the submission of the best practices of NQTL compliance. He's an expert consultant to the MIA. And he's a co-author of a model data request form, which is one of the things that we think we want to look at as we move forward with this. So with this information, I ask your consideration. Thank you for your consideration and ask for your favorable report. And I'm going to turn it over. Do you want you first? Over
Thank
to
you.
Mr. Cooney.
Thank you for your testimony. Hi, how are you? Good afternoon.
Hello. Thank you, Madam Chair.
You're welcome.
For the record, I'm David Cooney, Associate Commissioner for Life and Health at the MIA, testifying in support of House Bill 1085. This bill was introduced in response to the MIA's interim report on NQTLs and data that was submitted to the General Assembly on December 1st, which outlined the challenges with the existing reporting process and included 8 specific recommendations for how to improve the efficiency and effectiveness of the process. The MIA's top recommendations from the report were related to reducing the volume of NQTLs carriers are required to file with the MIA and giving the MIA additional enforcement tools in the event a carrier submits a deficient report. I'll address the rationale for reducing the number of NQTLs. And most importantly, I want to stress that reducing the number of NQTLs will not in any way reduce the impact of the MIA's work in this area. On the contrary, the streamlined process proposed in this bill will increase the impact of the MIA's reviews, as it will enable the MIA to expedite the process and reach parity determination sooner by eliminating unnecessary burdensome requirements that failed to add value to the consumer or regulator or otherwise detracted from the in-depth reviews we have been performing. While it's difficult to grasp and fully appreciate the complexity and time-consuming nature of these analyses until you've actually sat down and attempted to do one, I can't emphasize enough that it's simply not possible to complete an in-depth analysis of all NQTLs at the same time every year as required under the current statute in any kind of timely manner. To address this issue, HB 1085 will require the MIA to review at least 4 NQTLs every other year for every product offered by each carrier in Maryland, prioritizing the NQTLs that have the greatest impact on member access to care. While this sets a floor that focuses on the most impactful NQTLs, the MIA can review additional NQTLs as the process is further streamlined in the future. These changes are critical Because due to other regulatory commitments, if we must continue with the status quo, we'll either be forced to perform only cursory reviews, which are unlikely to uncover violations, or we will continue with the detailed reviews, but the process will remain protracted and the ultimate relief to Maryland consumers will be delayed.
Were you done?
Yes, thank you.
All right. It's okay. I was going to give you another few seconds. Go ahead.
Good afternoon,
Good
Madam.
afternoon.
My name is Mary Quay, Associate Commissioner for Market Regulation at the Maryland Insurance Administration, or MIA. Thank you for the opportunity to speak in support of House Bill 1085. I want to focus on the additional enforcement tools included in the bill. If the MIA cannot make a determination that a practice complies with the Parity Act because an analysis report is not sufficient to show compliance, the proposed bill would allow the commissioner to order a carrier to modify or cease the conduct or practice. For example, if the carrier has a requirement for mental health care facilities to meet more criteria than comparable medical care facilities, in order to join a network, it makes sense to order the carrier to remove those additional criteria rather than to say the carrier cannot have any standards for admitting a provider to its network. Another enforcement tool in the proposed bill is to require a carrier to submit periodic data related to a conduct or practice. Data is helpful in determining whether the application of an NQTL in operation meets parity requirements. The bill would allow the MIA to require a carrier to run an analysis using a quantitative threshold for applying an NQTL. For example, if prior authorization is required for high-cost treatments, then we would expect that high cost would be presented as a threshold with a dollar amount. If it is not, this bill would allow the MIA to require a carrier to perform an analysis using a dollar amount to define high cost to determine if prior authorization is comparable for mental health and medical treatments. In addition, House Bill 1085 would allow the MIA to pass through the costs of the review after the determination that the initial analysis is incomplete to the carrier. Thank you.
Thank you. And thank you both for, actually all of you at the MIA, for always being available for us. Okay. It's great to see you in person and not virtual. Go ahead. Next, please.
My name is Henry Harbin. I appreciate the introduction, Doug Cullison. I just want to make a few key points. One is that Maryland has long been a leader in the parity efforts in both the state and federal, and has also been recently recognized for the last 2 years as being a leading state in the enforcement of MAPEA. And they are doing very detailed work reviewing these lengthy plans and providing plans of corrections and issuing fines. I would add that the DOL and CMS recently recognized the MIA and its quantitative templates as a part of its audit tools as a best practice nationally. I've been advising several states, 4 states now, including MIA, and I wanted to add that the Department of Labor and this issue of how many NQTLs should you do per year. Well, the Department of Labor itself only looks at 4 NQTLs a year when they are opening up a comparative audit. Now, they're free to go after other things and complaints and broaden that, but as a routine basis, and I think that's a good model to follow for Maryland. The other 3 states that I work with, separate from MIA, only focus on 4 or 5 NQTLs every year. So I think requiring, 14, 15, 18 NQTLs every year or even every other year would really impair the effectiveness of this whole effort. I think even though Maryland's been doing a great job the last 2 years, I think they would be a lot more effective if they weren't doing 14 NQTLs. The final issue I'd like to say is that, a lot of states are asking, they are doing, a lot of NQTLs and they're doing them every year. But what we have reported, and many of the people I've talked to around the country, is these are very cursory reviews. And they don't do the details, they don't do the documentation, and they don't do any of the sanctions. So it leaves a situation where you have states that are not really enforcing the law. Thank you very much.
Thank you for being with us. We really appreciate it. I'm going to open it up for questions now. I'm going to start on my right, Delegate Hill.
Thank you, Madam Chair, and
You're
thank you,
welcome.
Madam Vice Chair, for the bill. I just want to get some clarity. So we're pulling back some rules that were onerous, but it's not clear to me whether those reviews were actually being done at 20 hours per review. It sounds like we just were failing to get it done. And then the other thing is fewer NQTLs, but there's a price of 680,000 or whatever, but we can pass the price on. So I'm kind of trying to figure out the fiscal note too. Why is there an increase in price if we're doing less?
Sure. Excuse me. So to answer the first question, we have been doing the detailed reviews on every single filing we've had, but we haven't reached substantive parity determinations, any of them, because we've had to do so many and we haven't been able to get to that point. It's a very long process. So we're doing it, but we haven't finished the process because it's too onerous and burdensome. And as was mentioned, we have already issued orders with significant fines against the companies just because the reports were not sufficient. So we're doing the work, but we haven't been able to complete it. That's I think the first question. The second question is the fiscal note, and I don't have the exact numbers, on hand, but for every company, even though it is fewer NQTLs that we're looking at now, just the number that is still proposed in the bill, it's still going to take that same amount of time per NQTL. And the initial review of when the companies file the reports with us, that's still on the state's dollar. What the law says is if that first review is insufficient and we have to request additional information after that, then at that point, the carriers have to pay for it.
You're welcome. Any other questions for this panel? Seeing none, thank you very much. Really appreciate having you. Next, we have Dan Martin. And I'm sorry to say you're by yourself. But you're enough, right?
So you get to hear me twice. So thank you very much. Pretty general support for this bill and the next bill. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in support of House Bill 1085. It's been 30 years since Maryland passed the first state mental health parity law in the nation. And I actually, back in 1993, and I actually went back and pulled the MGA membership from that year. And as it turns out, only 4 legislators are left from that year, including HGO's very own Delegate Sandy Rosenberg. So that's wonderful. And since then, Congress passed a national behavioral health insurance parity law 15 years ago. But regardless of these legislative steps, discriminatory practices and failure amongst payers to comply with statutory requirements continue unabated while the demand for mental health and substance use care continues to grow. Another interesting bit of history, the Maryland Behavioral Health Coalition that my organization chairs, that many of you are familiar with, now counts over 100 organizations from around the state as members, actually got its start in 1993 as just 4 organizations fighting and advocating for that parity law that we passed. And it's 30 years later now, and we're still fighting for the proper enforcement of that law with the Behavioral Health Coalition. But now, thanks to the legislation that this committee spearheaded in 2020, and to the stellar work of Insurance Commissioner Brain and the Maryland Insurance Administration in implementing that work, we have this eye-opening report from 2023 and recommendations for new reporting requirements and regulatory enforcement authority that will give us the best chance that we've had in a generation to ensure that these critical anti-discrimination laws are appropriately implemented and vigorously enforced. And so I know there are slight differences between this bill and the next bill coming up. Let's get them both to subcommittee, hash them out there, but make sure that we pass something and create some kind of product this year that really helps to make sure that Marylanders are getting access to the mental health and substance use care that they're paying for and that they deserve. So thank you very much.
And thank you for your work with the committee, okay?
Yep.
Are there any questions? Seeing none, thank you, Dan, for working with us.
Thank you.
We have now a favorable with amendment panel. I have first Nsika, followed by David Lloyd and Matthew Scelentano and Allison Taylor. That's the favorable with amendment panel. Lori, you sure you don't want to join this panel? Just kidding. Go ahead. Who would like to get started?
I'll go.
Yes.
Madam Chair,
Thank
members of the HGO Committee, thank you very much for the opportunity. I'm here today on behalf of the League of Life and Health Insurers, favorable with amendments on House Bill 1085. First and foremost, we are very much willing to engage in discussions on this bill and the other efforts introduced, and we'll be at the table to work on this effort this session. We appreciate the sponsor's recognition that these reports have proved challenging for both carriers and the MIA. Accordingly, we appreciate that House Bill 1085 includes a number of provisions to focus the reports on the review of the non-qualitative treatment limitations identified by the Commissioner as having the greatest impact on patient access to care. League members understand that access to mental health and substance use disorder treatment remains a critical issue. Rather than creating burdensome regulations and data polls that don't solve the issue, we think the state should focus their efforts on promoting policies that support increasing mental health, substance use disorder treatment, workforce and innovative models of care, as well as prevention and early intervention in communities. Thank you to the sponsor and the MIA for bringing this bill forward, and we promise to remain engaged to get this effort to the finish line. Thank you very much.
Thank you. Next, please.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. First, I want to say I thank the MIA for the hard work that they've done and the recommendations that they've done here. I'm not at all surprised to hear their assessment of the level of work it is to review. Kaiser's experienced the same thing. We've had 84 staff members who work on this report, including 63 who provide substantive data, and then followed by a review from the legal and compliance departments. So, our objective through this process is to submit the right information, get a review from the MIA about where we're in compliance and where maybe we're not, and then be able to adjust and pivot before the next report is due so that we can address whatever issues there are. So we'd like to work with some amendments to make sure that that goal is met and that these reports can be meaningful to you all and really address the issues here. So Kaiser's here in good faith. One idea I want to put out there as an amendment is rather than continue these indefinitely, continue them through 2030 and then have another check-in like we're having this year to see how it's going and if changes need to be made. So, looking forward to hearing from everybody and certainly working with the sponsors of both of these two bills. Thanks for the opportunity.
Thank you for being with us. Next, please.
Good evening, Madam Chair, members of the committee. I'm Ann Seacott on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We're very appreciative to be having this discussion this year. We're appreciative to both the sponsor of this bill and the next bill. And we know that we will be at the table helping to work with you all and other stakeholders to come to yes somewhere in perhaps the middle. We are supportive of House Bill 1085 with amendments. We think that there are some provisions that are in 1074, the next bill, that are a little stronger that we prefer. And one part that I'm going to just spend a minute on is those NQTLs that the sponsor mentioned earlier. I'm just going to say treatment limitations. So just as a reminder, there are very many of these treatment limitations, all of which by federal law, carriers have to be analyzing for compliance with parity. So they have to be in compliance with all of them. What we're talking about is how much are we going to say they need to report and which ones are the MIA going to really look at in order, in the process of holding carriers accountable for compliance with this federal law. So, we understand, there are going to be discussions, I think, about the number. One thing that we do feel is a better, stronger strategy is to not necessarily tell the carriers ahead of time what are if they're 4 or 5 or 7 specific measures that are going to be used. Maybe it's, collecting more, but then not telling them exactly how many, which specific ones they're looking at, just so that there's, some sort of element of an audit, if you will, and not just, hey, we're going to look at this and that's all they report on. So with that, we are looking forward to continuing this discussion.
Thank you very much for your testimony. I really appreciate it.
Thank you, Chair, Vice Chair, and members of the committee for the opportunity to testify on behalf of Inseparable, a national nonprofit focused on closing the treatment gap for people with mental health and substance use disorders. I'm David Lloyd, Inseparable's Chief Policy Officer, and actually previously I worked for former Congressman Patrick Kennedy, who was author of the Mental Health Parity and Addiction Equity Act of 2008, which has been in place now 16 years. So Inseparable supports HB 1085, with amendments to strengthen parity oversight. We're deeply grateful for Vice Chair Cullerson's work and leadership on parity and attempting to make mental health and addiction parity a reality in Maryland. Specifically, we believe the HB 1085 can be strengthened in several ways. One is really ensuring that plans are conducting all of the federally required parity compliance analyses that federal law mandates that they conduct, with allowances for MIA to prioritize enforcement across product lines and for specific non-quantitative treatment limitations. We also believe, as Ann said, that removing the advance notice of which NQTLs will be analyzed is actually pretty important. Otherwise, it's difficult to hold plans accountable. And just more broadly, health plans have these requirements of doing compliance analyses have been in place for about over 3 years now, and it's critical that health plans be held accountable. The Department of Labor and Health and Human Services, the federal level, reported that plans are failing pretty miserably and not even conducting parity compliance analyses. So it's really important to bring additional accountability, to this area. And so we respectfully request that the committee favorably report 1085 with amendments. Thank you.
Thank you very much for being here today. I'm going to open it up for questions now. Are there any questions for this panel? Seeing none, thank you so much for being with us and for working with the sponsor. I have in our favorable panel, Lori Doyle. How are you, Lori?
Thank you, Madam Chair. Lori Doyle,
welcome.
on behalf of the Community Behavioral Health Association of Maryland. Let me start by saying that we are also looking at this bill and the next bill together because they're both trying to solve the same problem, and that is the problem of carriers not meeting the requirements on parity reporting. I want to thank Delegates Cullison and Bagnall and the MIA. If I could have chosen a different stance, it wouldn't have been unfavorable. It would have been less favorable. So in comparison, we're trying to get the strongest bill as we can, and we're assuming it will go indeed to subcommittee, and we'll take bits and pieces from column A and column B and make it the strongest we can. This is so important because we have had providers go to the MIA with parity complaints only to be told that the MIA cannot make a determination because the carriers have not provided sufficient information. So an unscrupulous carrier could dodge a parity violation by simply failing to provide the adequate information. I mean, that's like me saying, I can't be charged with tax fraud because I didn't bother to file to begin with. It's a problem. So we prefer 1074 over 1085 because the requirements on reporting are more stringent and because the penalties for failure to report are more stringent. I don't know what the sweet spot is on NQTLs. It's 4, it's 14. I'll leave that to brighter minds than mine. But I just think about the 15 years since the Parity Act has passed and how many people with mental health and substance use disorders have been, left behind and not treated because the carriers are not complying with the law. So I look forward to working with you, Delegate Cullison, with you, Delegate Bagnall, in fashioning the strongest response that we can. Thank you.
And thank you, Laurie, for always working with us. We really appreciate your work, all of you, actually.
Thank you.
Are there any questions for Lori Doyle? Seeing none, thank you so much. And this actually concludes the bill hearing on House Bill 1085. Next, we have House Bill 1074, Delegate Bagnall, Health Insurance, Mental Health, and Substance Use Disorder Benefits, Sunset Repeal and Modification of Reporting Requirements. Will you be so kind and bring, I believe on your panel, You have Ellen Weber, right? Good afternoon, Ellen. How are you?
Good afternoon. Terrific. Thank you very much, Chairman.
Good. Thank you for being with us. Delegate, would you like to get started?
Thank you very much. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, here on behalf of House Bill 1074. You have my written testimony, so I'm going to summarize, and I've rewritten my testimony multiple times, but clearly this is such an important issue that we actually have two bills to get everyone to the table. I will reveal the mystery that we are actually working in collaboration. This is not a competition. I'm not going to ask you to pick your favorite. I know how that will go. So, we're trying to get to the same issue from two different approaches. As the previous panel talked about, in 2008, Congress passed the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act of 2008, requiring insurance carriers who offer mental health or substance use disorder benefits to offer equally favorable benefits, between mental health, substance use disorder, and medical and surgery benefits. The Parity Act is exactly that. It's ensuring access to behavioral health and bringing parity to behavioral and somatic care. I do want to thank the previous panel for not making me say NQTLs over and over, because I think we understand the gist of it. But to try and ensure compliance, an emergency bill was passed in the legislature in 2020 that required insurance carriers to report to the Maryland Insurance Administration in great detail how they are complying with the Parity Act. And as you've heard previously, those reports are not getting to the problem. As the saying goes, the devil is in the details. And these reports are lacking the details necessary to even determine compliance. They are essentially checking the box that it's done, but the explanations lack the data to actually do the meaningful comparison. So House Bill 1074 is about enforcement. This is a bill that gives the MIA, based on their recommendations, the tools they require to ensure carriers are offering equal benefits for behavioral health coverage. First and foremost, 1074 lifts the sunset established in House Bill 455 in 2020, ensuring the MIA will continue to receive compliance reports from carriers for as long as is necessary to ensure Parity Act is being adhered to. 1074 also alters some reporting requirements to clarify what data points are required under carrier compliance reports and provides greater enforcement capabilities to the MIA should they find that a carrier is being non-compliant to the Parity Act. Now, these changes will work to more efficiently ensure that carriers are offering equality in their behavioral health coverage to their recipients. We're working with the MIA, we're working with stakeholders and Madam Vice Chair, who is the chair of the insurance subcommittee, and we're also working with our Senate partners to ensure we get meaningful data to aid the MIA in doing their very intense investigation and enforcement, which also will create meaningful framework for the carriers in complying with these reports. I do want to note that the fiscal note reflects the bill as drafted, and we have been working to find that right balance of information gathering to help in the essential work of the MIA, and also ensure that we are working smarter and more meaningfully. So it does not reflect the proposed amendments, which will help streamline and focus the work. You will also see that revenues are indeterminate, but alternately, we don't want to be fining carriers. We want them to demonstrate compliance because they're complying, but we need to give the MIA the tools that they need to ensure that compliance. So when access to behavioral health care is more important than ever, it is paramount that we have the proper legal mechanisms to ensure that Marylanders are receiving equitable coverage for care through their carriers. And for all these reasons, I respectfully ask for a favorable report on House Bill 1074.
Thank you, Delegate. Ellen?
Thank you, Madam Chair, members of the committee. I'm Ellen Weber. Thank you for the opportunity to testify in favor of 1074. I'm with the Legal Action Center, and we convene the Maryland Parity Coalition in Maryland. I also want to thank Delegate Bagnall for introducing 1074 for Delegate to Delegate Cullison for working out the differences between 1085 and 1074. And I would really like to thank the MIA for issuing its illuminating report and doing all that it can to try to enforce this law. The most important step that this committee can take to ensure the enforcement of the Parity Act is to explicitly place the burden of persuasion on the carriers to demonstrate that their plans comply with the parity standards. That should be both in these reports and in any investigation that the MIA conducts. Now, this is essential for 3 reasons. First, the MIA proposed this very standard in 2020. The carriers opposed, and as a result, the MIA has not been able to make a substantive decision of compliance for any of the carriers. The MIA should not have to operate under this handicap in future reviews. It's a waste of time and it's a waste of money. The second point is federal law places the burden of persuasion on the carriers for compliance reporting. Our testimony provides that a legal analysis. I'm happy to explain more if there are questions. And then third, carriers possess all the information that's needed to demonstrate compliance. They have the persuasion burden on grievances and appeals. Because of that, the same should apply here. Now, the remedies that flow from this persuasion standard will break the logjam that's been created by the carrier's playbook. They submit incomplete analysis. They don't provide the information that the MIA then requests, and then they ask for a hearing after any type of penalty is imposed. So Marylanders are on the losing end of that. So regrettably, after all the work that this body has done, all the work of the MIA, we are no closer to ensuring equitable access and coverage of mental health and substance use services than we were 4 years ago. So we really respectfully request a favorable report on 1074.
Thank you.
Thank
For
you.
your testimony. Questions for this panel? For the sponsor and her panel? I'm looking left and right. Seeing none, thank you both very much.
Thank you.
So I'm going to call Ann Seacott, David Lloyd, and Lori Doyle. Dan Martin. Let's get everybody up who's in person. Live and in person.
Good afternoon again, Madam Chair, members of the committee, Ann Seacott, on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence in support of House Bill 1074. There's not a lot more to say different. We really do want to work toward the strongest provisions that we can find related to all of the different factors in the parity compliance reporting. Thank you.
Yes, thank you, Madam Chair and members of the committee. Again, David Lloyd, Chief Policy Officer at Inseparable. We support HB 1084, and particularly the burden of persuasion is a critical issue. That is where a lot of this gets kind of bollocksed up is that you get plans submitting incomplete information, and there's this back and forth that takes up a tremendous amount of time. And so having the burden of persuasion on the plans where it should be, that's consistent with federal law, is really important to making sure that people have access to care. And then also the patient protections, which Ellen Weber mentioned, are also critical. And one final issue, while I believe it's critical to do deep dives on NQTLs, that a scattershot approach does not work well, that you really do need these deep dives. When someone makes a complaint to the department, I think it's really critical that each of those complaints be analyzed through a parity lens. Because if that's not happening, the individual who's having the complaint about a particular treatment limitation essentially has no rights under the Parity Act as far as the state of Maryland is concerned, if there's no evaluation of the parity compliance analyses. So I think that that's a critical component in making sure that your health plan is complying with the law, and that you get remedies as a patient who's being denied care if your health plan has not demonstrated that they're in compliance with the Federal Parity Act. So thank you again.
Thank you.
And ask that you favorably report HB 1085.
Thank you. Lori?
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland in support of this bill. And unlike my colleague, Dan Martin, you don't have to listen to me again. So I would just say I really look forward to working with you, Delegate Bagnall, and coming up with the best product possible.
Thank you, Lori. Dan?
Madam Chair, Dan Martin with the Mental Health Association of Maryland, here in support of House Bill 1074. And the testimony is pretty much the same as the last bill. 30 years, like I said before, it's been 30 years since Maryland passed the first state mental health parity law in the nation. And thanks to the hard work of this committee and the Maryland Insurance Administration, we now have in front of us two bills that have the kind of, the nuts and bolts that we can put together that gives us the best opportunity in a generation to really make sure that we are enforcing these critical anti-discrimination laws. And so I urge your support for this bill and look forward to working with you to hash everything out.
Thank you very much. I see Delegate Lewis.
Thank you, Madam Chair. Thank you, panelists. Thanks also Delegate Bagnell for the bill. I just realized that it's been 10 years since I learned what the heck parity was. And some of you at this table taught me what it was when I was at the Health Exchange. I'm looking at you, Lori Doyle. I can't believe we're still talking about it, but it seems closer. So my question is for Ms. Doyle. I'm a little confused, I admit. I noticed that Vice Chair Cullison has a bill on parity and reporting, and so does Delegate Bagnall. And I noticed that you came favorable on Delegate Bagnall's bill and unfavorable on the Vice Chair's. And I just want to make sure I understand what is the difference between these bills and why is one viewed more favorably by you?
No. And I'm probably not the best one to explain all the minutia of the two bills. And really the unfavorable and favorable was just a judgment call on my part on how to record that we felt there was a difference between the two bills and one was stronger than the other. I think it really for us came down to the persuasion argument that was just made by my colleague to the right, and also the penalties to be able to provide fines that are substantial enough to get the carrier's attention. I think sometimes, if a carrier does not complete the report, they're subject to a fine, but it's seen in many cases, I think, as the cost of doing business. And I think we have to get serious about reining this in and changing behavior. So I hope you don't take my unfavorable as a true unfavorable. It's really a comparative unfavorable to the other bill.
Thank you, Delegate. Any other questions? Okay, seeing none, is Courtney Bergen here? Please let the record show we called Courtney Bergen and she is not virtually and she is not here. That concludes the hearing on House Bill 1074. I appreciate the discussion and the time and testimony of the witnesses. And Delegate Rosenberg, I'm going to ask you to come over here and sit for my bill. The last bill of the day. She likes, that's the next one.
Yes, it is.
Yeah,
Okay. Okay. House Bill 932, Health Insurance Utilization Review Revisions. Delegate, would you like some of your witnesses to come up with you? Okay, I know the feeling. David Lloyd, James Gutman, Melinda Duke,
So, thank you, Mr. Chair, members of the committee for the opportunity to present House Bill 932. I would recommend that you take out your cameras and you take a look at who is sitting at the table. Delegate Kerr is over there going, what? Because at this table, we have representatives of the insurance carriers and the healthcare providers. They don't often come to the table very often, but they are. And the fact that they are is a testament to the commitment that they have to making sure that we can improve our healthcare system for our residents in Maryland. This bill addresses the issues that are raised by constituents. All of you have heard this, and healthcare providers over the last few years regarding the practices and processes that healthcare insurance or health insurance companies use to approve medications and medical procedures. Which is often called prior authorization and utilization management. I suspect that all of you have had the experience and inconvenience of having a prescription that you've been successful on and you've been taking, only to have it denied after taking it for a couple of years and having to go through a lengthy grievance process. So let's think about some other serious kinds of situations where this might happen. So imagine that you were hospitalized several times because of severe flare-ups of your disease, and you were prescribed a drug coming out of the hospital and the carrier approved it. But a few years later, the carrier says it will not reauthorize your treatment and you must try another less expensive therapeutic equivalent drug. The problem is not only that your condition has been under control for 10 years, and you have not had to be readmitted to the hospital during that period, but your doctor tells you that if the new drug does not work, you can't go back on the original drug that works so well because of the metabolic changes that have been made. Last session, so this is why the bill is here, and this has been a long-standing issue. Last year, this committee heard legislation that would have revised the processes used by health insurance carriers. And after hours of debate and discussion with these folks here last session, we couldn't reach any resolution. So at the request of the chair, we began meeting in the summer. There were a total of 11 meetings on this bill. And it began as a very big group of carriers and providers. And we took the first few meetings to really define the problem. And then we began to get into a smaller work group that would actually begin hammering out the language. I am very happy to tell you that this bill is the product of those negotiations. The sign of a good bill, as you all know, even those of you who have only been here a couple of years, you already know, is that if nobody is completely happy, then you've reached a compromise. And that's what this bill reflects. It's a very long bill. If you look at it, it's like 32 pages or something, but it breaks down into basically three sort of areas. The first is access to medication. It actually reduces the volume of medication subject to prior reauthorization. It also allows a patient to stay on a drug that they have been taking and being successful at, simply with the attestation of the doctor saying this patient has been successful on this drug. And these are, the patients that are on drugs like for mental health illnesses, autoimmune disease, chronic conditions such as hypertension, epilepsy, diabetes. We knew at the beginning of these discussions that the process of utilization management was used not only for patient safety, and I want to be clear that that's part of the analysis that was going into that, but also for constraining drug cost. We hear a lot about that in this committee. I am in full support of lowering healthcare costs, but that cost can't come at the expense of patients who have been well maintained at a drug, sometimes for years. This provision does not prevent carriers from making that initial prior authorization with a newly diagnosed illness to use a less costly or alternative, nor does it prevent the prescriber or patient from making a decision to try a different drug. It puts the decision for reauthorization back in the in the responsibility of the provider and the patient. In reducing the number of prior authorizations, it ensures that when a patient changes carriers, a prior reauthorization will be honored for the first 90 days while the new carrier conducts its own review and affirms that the dosage changes do not require another prior authorization. So that first bucket, access to medication. Second bucket, increasing transparency and communication. The bill requires that any communication from a carrier when there's a denial of healthcare services states in detail the actual and factual basis for the decision. The providers told us that this was often lacking, explaining the reasoning why the healthcare provider's request was not medically necessary or why it didn't meet the criteria and standards. It requires that if any additional information is needed to make a determination, the carrier must provide the specific information that's needed. So the specific lab test, the specific diagnostic test, or any other medical information. And it tightens the standards and criteria that must be used by carriers in making utilization determinations. And lastly, we want to look towards the future. So we're looking at potential opportunities. We have included in this asking the Maryland Healthcare Commission and the Maryland Insurance Administration to review these initiatives regarding review initiatives regarding establishing programs to exempt providers from prior authorization requirements if certain criteria are used. This is the notion of value-based care. So if you were around 2 years ago, you remember what we were talking about, where the focus is on outcomes, and healthcare providers have the option of joining into those plans. So we'd like to see more get into that. Concerns were raised very recently as about 10 days ago, that the impact of the bill, including costs and medical outcomes, were not fully explored in our discussions in our final draft. So now we are discussing an amendment, and I will be offering an amendment in the subcommittee to require an impact assessment and report in 3 years. This bill is truly a product of collaboration between the stakeholders that come from very, very different perspectives. I believe that it's a well-balanced bill that considered the concerns that were raised by healthcare providers, consumers, and payers, and struck a good compromise. It will protect patients and alleviate the strain on providers, but remains intact the ability to conduct a utilization review. I want to thank you for your consideration of this very long bill. And I am going to ask for your favorable report, and I'm going to turn you over to Tommy Thompson.
Good afternoon. How are you?
Good afternoon, Madam Chair and Madam Vice Chair and sponsor and honorable members of the committee. Thomas Thompson on behalf of the Maryland Psychiatric Society and the Washington Psychiatric Society, physicians who obviously practice in the mental health space, in full support of House Bill 932. This bill actually began 4 years ago for the two societies as an idea in the Senate, and that idea was only 4 pages and no fiscal note. And what happened, it got the attention of no one but the carriers, who came in and mopped the floor with me. But what happened after that was marvelous. MedChi, our sister organization, who we're a member of, came to us and said, let me show you how it's done. And we picked up a champion, and that was Delegate Kerr. And we didn't get it done then. And that was no fault of Delegate Kerr's. There's just a lot of moving parts to this. So we picked up another champion along the way, and that is the vice chair of this committee. And then with the help of the chair, we were able to bring everybody to the table and have a real discussion about this bill. And so normally when I'm the rose between 2 thorns, every other bill, I have now 2 roses sitting next to me. And I say that because I believe truly that this is the most meaningful mental health bill that you will see this session. And why is that? Because disruptions to mental health care, which is typically pharmaceutical, usually supplemented with therapy, when that's disrupted, even for the shortest period of time, the impacts are severe and they are very impactful to the patient. They can become a danger to themselves. They can become a danger to the others. They can lose their lives, their liberty, their home, their children, their jobs. All because a disruption in their treatment, which is usually through utilization review. I think we found a way to still have utilization review remain in place and be meaningful to the carriers, but we have found a way to allow the patients who are successfully undergoing treatment, continue that treatment and remain healthy and remain active in their community. And I think this is a wonderful bill. We would love to work with you and whomever else to make this a perfect bill that you can send to the floor. Thank you.
Thank you, and thank you for your advocacy. You're certainly not alone today. Next, please.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente in full support of this bill. I want to thank Delegate Kerr, Delegate Cullison, my provider colleagues, and the other carrier colleagues for their work on this. This bill really provides two solutions. The first is a legislative solution, as you've already heard. The second is a technology solution I think is equally as important, and that will institute a real-time benefit check tool where providers can in real time check a patient's benefits to see what medications are available to them that don't require prior authorization, and then pick those if the physician is comfortable with that. Carriers are different in the way that they do this. I can imagine that's a huge pain for physicians. And so I hope that this really does help address that piece of this issue as well. I think it's going to be referenced in a later panel, so I did want to call your attention to the fact that on one provision in the bill, there is a carve out for a group model HMO as it relates to reauthorization only within their closed network. That reflects the fact that the Kaiser physicians and health plan have reached agreement on how to do reauthorization. They have 97% formulary adherence, and I think probably the best pharmacy rates and negotiations in the country, if I can brag about them a little bit. So we're very proud of that, very proud of this bill, and urge a favorable report.
Thank you. Next, please.
Madam Chair, members of the committee, Matt Celentano here today in favor of House Bill 532. Don't get used to it. No.
I
No.
was gonna say, that is take a picture.
I won't steal all of Ms. Kaufman's thunder, but I think that you'll hear, you probably are aware, we were opposed to this bill last year. We still don't like a lot of the stuff in this bill. I'm sure Ms. Kaufman doesn't like a lot of the stuff in this bill, but we spent the last 15 months really digging down, and it has been a tremendous amount of work. I cannot thank all the stakeholders involved. I can't thank Delegate Kerr enough for getting us going, Madam Chair, Madam Vice Chair, members of this committee for having really deep conversations with us about how to move the ball forward. The fact that pretty much everybody up here doesn't like the bill that much means that it's probably a product you can be proud of. And I really appreciate the opportunity to let us take the time to dig through it, to get to a place where we can come to the table and say yes. So thank you for the opportunity.
Madam Chair, may I take a moment of indulgence because I neglected in my testimony. There is, we've named a number of people that have been very instrumental in making this bill happen, but the person who has probably been the real workhorse of this bill is Dana Kaufman. She was the person who was organizing the meetings. She was the person who was taking notes. She was the person who was checking in with both the providers and the carriers and really kept us moving in a forward fashion. And I cannot express my appreciation enough to Dana for helping us to get to this product. So with that, I'll turn it over to you.
Thank you very much. And for the record, my name is Dana Kaufman, and I'm here on behalf of MedChi and several other medical societies. If you want to see all the nuts and bolts that are in this bill, my testimony has a comprehensive summary, but I think that this bill shows that if you have patience, good things will come your way. This bill has taken 3 years to get to you. And why I understand that the carriers don't love it, we didn't get everything we wanted in it, but I really like it. I think that this bill will really bring meaningful change to a situation that we have been working on for many years now. The Maryland Psychiatric Society really sparked the discussion on this, and I very much appreciate Mr. Thompson and the society for doing that. And I could not go anywhere for quite a while without hearing the stories about patient care being delayed or denied, or just the administrative burden put back on physicians. And what I really wanted to be able to do is say that, and for you to be able to go back to your constituency and say that we did bring about meaningful change. We are changing the pendulum. We are bringing it back to the center. It was not easy. We had, as Vice Chair Cullison said, we had over 11 meetings this interim. We had multiple drafts, and at times it did get heated. We had gentle prodding from the chair to get it done in her way. And we did. And I'm very proud to present this bill to you. I think it's a very good bill. I think it'll change the dial. We are going to be working with Vice Chair Cullison on some technical amendments offered by the Maryland Insurance Administration. And more importantly, we will be working with her on the study language for the fiscal implications. The only way to be able to really show is to have the data that we can make informed decisions. So with that, I thank you very much. I thank the chair, the vice chair, everybody at this table, Delegate Kerr, and I ask for a favorable vote to bring it across the finish line.
Thank you, and thank you all for your testimony today. I'm going to open it up for questions now. To my right, I see Delegate Hutchinson, followed by Johnson.
Thank you, Madam Chair. And, there weren't many testimonies that I remember from last year, but boy, that was one I remember. So to see where you are, 365 days later is remarkable. I don't want to, this is for Delegate Cullison, so I don't want to be a spoiler alert, but I do see that there's some favorable with amendments coming up. I am sure, as they probably know how we work here, that you probably have seen them. Do you have any comments on the amendments that we're about to hear about?
Well, the amendment that I know most is the need for the impact study, and because we didn't have that in there, and we are working on that right now.
And as a follow-up, you agree with the study, correct?
Everybody agreed with the study, yes.
All right.
Correct.
Good. Delegate Johnson, followed by Bagnell, then Shalega.
Thank you, Madam Chair.
My pleasure.
The question is for Matt. Matt, can I hear your position one more time on the?
Don't push your luck, Delegate Johnson.
Thank you, Madam Chair.
You're welcome. No, you're not. You didn't have any of that stuff we talked about yesterday. Delegate Bagnell.
Thank you, Madam Chair. We've had some impressive panels this session before us, but I think this might be the most impressive, not since the ophthalmologist, optometrist, agreement have we been this excited. I did want to give Vice Chair Cullison an opportunity to speak to the fiscal note. The text of the bill is very dense. The fiscal note is also very dense. So I just wanted to ask if you had a comment on it.
So, as I said in my testimony, there was some expectation that there would be a fiscal note, but it's really indeterminate. It really, we have no way of knowing because we don't know how many people this is going to apply to ultimately. It's a much smaller number than the full book of business of, each carrier. So you can't look at the overall, all of the members in each carrier to determine it, because only a small percentage of them will be taking the bill or will be taking advantage of the reauthorization. It's the reauthorization piece that could potentially add the cost. So I think that we need the experience to see how it ultimately affects, and we'll have 3 years to study it, to gather that data, to tell us. But, we've seen these kinds of fiscal notes before when we make some dramatic change in service delivery. And in my experience, in the 14 years that I've been here, not once have we come back and said, oh my God, the sky fell. So we do seem to find ways to adjust and to make adjustments. And that's what I'm hoping we can do to if given the opportunity, to move forward to, make the, fiscal note as small as possible.
Delegate Shalega.
Thank you, Madam
You're
Chair.
welcome.
Congratulations. We are so excited that you've put all the work in. We can't thank you enough. I mean, truly, this is an issue when we're in the community that we hear about all the time. You know, people who say, you know, my medication was changed, but then, you know, I'm really impressed, Dana, that you got your summary down to 3 pages. But, you know, the pre-authorization for procedures is huge that you were able to do that. It looks like in a cursory view, like 3 days, you got to have evidence why you're denying a patient to get her varicose veins treatment. That Medicare, and I think I've talked to Dana about this, Medicare has some pretty easy to follow rules on varicose vein treatment, yet for some reason, you know, other insurers do not do that. And, you know, a physician in that industry spent my ear for a half hour in a positive way about how hard it was and how many times his patients were denied. And, you know, 30% of them gave up. So, you know, hopefully in your study, you're also going to look at the savings that we're going to see there, right? I don't know how you capture that, but, you know, physicians back in office cost where, you know, some have offboarded that to another country to have their offices call again and again and again and again to the insurers. So I think in the end, we may see a savings on that end from both the carrier and the physicians, which ultimately helps the patient. So
I would agree, Delegate, and I will tell you that my as you said, you can't go anywhere in our communities. I mean, I get my hair cut and my hair, you know, she's cutting my hair and talking to me how she can't get her medicine. And my rheumatologist told me he has 24 people who only do pre-auths and re-auths. So, you know, that will be a great savings to him, I hope as well. So, I think you're right. We're going to see some balance here ultimately.
Delegate Shalega.
thank you. One final thought that I hope within the study or the, you know, this is so complicated. Talking to a dermatologist, you know, and the back end office staff at a Christmas party. Of course, you're at a Christmas party and you're talking about pre-op, right? And they're like, oh, somebody who can listen to me. And it was a delightful conversation. But, you know, she was explaining to me that they, you know, their patients, because we are in this unique state of Maryland, have insurance policies from all over the country. So, you know, those 24 people that are calling are struggling. So thank you all for putting the hard work in, and I'm excited to see how this is going to help everybody.
And I will add, you know, we will be looking at outcomes in terms, not just financial, but also health outcomes. You know, how many, you know, are there fewer emergency room visits because of medication changes or service changes? So yeah, it'll be designed to help us show the real impact of the bill.
Are there any other questions? Since I don't see any, I usually wait to the end. I have a couple of questions. First of all, I want to say thank you for coming to the table. We got this without a bill, correct? The work group.
Oh.
And I remember when we were not even done with session, how it was so disappointing that it did not pass the Senate. So I remember talking to you, Ms. Kaufman, and we said, we're gonna get it done in a work group. We're gonna bring people together. So you had more than 11 meetings. All the carriers were represented at every meeting, correct?
Yes, for the large group and the smaller groups, yes.
And in addition to that, all the carriers received all the amendments and all the different drafts, correct, of the bill?
Yes, we worked through the league who distributed those drafts, yes.
To everyone?
Yes.
Okay. So basically everyone was on board until 10 days ago.
That is my understanding.
So presently, there's a concern from one carrier, CareFirst, regarding the fiscal note, correct?
The reauthorization.
For that part. And that part of it, tell us about the DC law that deals with reauthorization.
DC has a law on its books that basically says that prior authorization can only be for medical necessity. It cannot be based solely on cost.
And Virginia has a law dealing with behavioral health, where, and by the way, CareFirst participates in DC and participates in Virginia. And what is the law in Virginia?
In Virginia, there's a law that basically says if you've been on a drug for a behavioral health drug for 3 months, then you do not need another authorization as long as you've been on that drug and your prescriber attests that you are doing well on that drug.
And although some of our carriers do not participate in other states like Texas, there are other states that have similar laws, correct?
There are other states that actually have laws that are frozen formularies or that freeze, if you do make a change, freeze where you can, that an individual can stay on that drug for the rest of the plan year.
And our law, where does it fall in comparison to other states? Are we the strictest or we in the middle?
Well, I would argue that the DC law is much more restrictive because it says that you can only use medical necessity. You can't use cost for your decisions. And our law will still allow a PBM or an insurer to require newly diagnosed individuals to try a less costly therapeutic.
So this basically, the people that will be helped the most are the people that have been on it for a while, correct?
Correct. If you have been on it and you have been well maintained and that is attested to by your prescriber, then you will have the option to stay on. Now, it's an option, of course, it's not a mandate. So if you decide that you want to try the other drug that is recommended, you can, but you will not be forced off of that drug, which I do believe is where the main concern and the negative health outcomes result.
So a young mom who has been on medication for epilepsy, who has been very stable for a couple of years and then is told, guess what? You can no longer be on that. You have to try something else. Who is in her car driving with her child and has a seizure. I mean, that is the impact of the decisions we make here. Isn't that so?
Correct.
And tell us about step therapy. 10 years ago, we did step therapy. How does that compare to what we're about to do here? And did the sky fall?
The sky did not fall. Step therapy was passed in 2014, but what was interesting is, again, step therapy was first introduced in 2013. It did not pass, so then it was reintroduced in 2014. And it basically states that, and we amended it last year. So before last year, it basically said if you had been on a drug for 6 months and your prescriber attests that you still needed that drug, that you could stay on it and you could bypass the step protocol. Last year, we also increased the step therapy law or expanded the step therapy law to provide for an exemption process for those individuals who may not have been on a drug for 6 months, but for many reasons, which would need to be attested to by the prescriber, would not want to take the step process or go through that step process. So, and we've also done it for certain breast cancer drugs and things like that. But to the best of my knowledge, we have never gone back to reverse that law. And as you said, the sky has not fallen.
And I have a question. Who's the best person to answer the following? Thank you so much. What percentage are we talking about for people? Is this a small number of people? Is it 50%, 40%? The people that this would apply to? And I recall being told this is a small number, like 17%. Who can elaborate on that?
So,
Do you want to go?
yeah.
The best person for this, one person.
Well, is it Matt?
No, Matt.
This would apply to the commercial market, so 18% of the insured population in Maryland.
So 18%. And that is distributed according to the different carriers, right?
Correct.
Correct. All right. So the compromise that we have here, the language, is the objective to see whether the sky is gonna fall and to try to be more certain with the fiscal note, correct?
Yes,
Because right now,
Study.
we don't know, it's uncertain, right?
correct.
All right, so all the carriers are on board now, correct?
With the study, yes.
With the study, all of them, including Care First,
Yes.
correct?
Yes.
All right. I want to take a minute to say thank you for meeting. You did not have a bill. You were not compelled to meet, and you took 15 months to meet in good faith to talk about this because it's an issue. You know how I got involved? I usually don't talk this much, right? So you must be shocked or ask this many questions. I just let you, guys, and ladies ask the question. I went to get my physical last year. And I go see my doctor. And she starts, and I won't mention her name, she starts talking and talking about this bill and about this problem. And she says how her staff has to spend all this time to help her patients, right? To get this reauthorization, right? And it was an hour went by and I'm like, come on, do the physical. And she's still talking and talking. She's gonna see this and be upset at me, but she did. So then I said to her, you know what? I had enough. Right there, I called Donna Kaufman. I said, I'm here with my doctor, my physical. Can you involve her in this work group? So she participated for all those months. And I cannot go anywhere when this is not an issue and it's a real issue. But I really think that the way this is being done here is balance because you all met, you discussed everything and you're willing to try it. And then we'll see whether it works with a study language. So I want to thank you for being willing to come in good faith and work on it. And for all the time that you spent on it on behalf of our committee. And I must remind everyone, without a bill, all right, 15 months without a bill. And I want to thank you so much, okay? Now we're going to call the next panel. And thank you for indulging me. I usually don't do that, okay? Thank you so much. So we have next David Loy, James Gutman, Melinda Duke, Daniel Dorothy, and Daniel Shutter. Can you come up, please? And please pull some chairs up. Did Michael Patty, did he leave? Is he here? Can you come up, please? Morgan Mills, can you come up, please? Thomas Thompson, can you come up, please? Oh, you did already. Okay. And Seacock? All right. Who would like to get started? And good afternoon. Thank you for being with us and for being patient. I know this is the last bill of the day. We thank you on behalf of the committee. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Dan Doherty here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons in full support of this legislation. I would like to start by repeating the thanks to Delegate Kerr, to Senator Klausmeyer, to the Vice Chair, to the Chair in having this move forward. Most importantly, since we were working without a bill and there had been a request that we meet, I want to thank Ms. Kaufman for herding cats and getting us all together. She did a marvelous job. She was wonderful to work with. This bill is one, and I echo what she said. I truly like it. Bills like this have a lot of provisions in it, and a lot of them go by the wayside. But when you come out with key provisions that help the patients, that help the providers treat the patients, save time, it is very valuable. We worry about access to dental care. I think this bill is going to free up a lot of time in a lot of dental offices, and we will have better access just because of this bill. And that's a small benefit of the bill compared to the others. So with that, I thank everyone who was involved. I thank this committee, and I would urge a favorable report.
And thank you for your testimony today. Next, please. Good afternoon, sir. How are you?
Doing well, thank you. Thank you, Madam Chair, Madam Vice Chair, and members of the committee. David Lloyd with Inseparable. We strongly support this bill and are deeply grateful to Vice Chair Cullison and Delegate Kerr for their leadership on this effort, and thank everyone who's worked on this bill. I just wanted to point out two critical provisions that we think will make a real difference. One is, just broadly speaking, for mental health and substance use disorders, prior authorization is a critical issue. That when people are stable on medications, there's a latency period, and like having to switch off medications and try new medications can be a very involved process that can be very destabilizing. So this bill will have a major impact. Secondly, this bill taking what is already Maryland law, Maryland mandates use of the American Society of Addiction Medicine criteria, something that came through this committee. This bill would also, within the scope of criteria from nonprofit clinical specialty associations, would require use of similar criteria on the mental health side. So it's nice to bring what's already law in Maryland on the substance use disorder side and make that also true on the mental health side. So thank you again, Vice Chair Cullison, for your leadership, and we urge your favorable report on this bill.
Thank you for your testimony. Next, please.
I'm Melinda Duke. I'll go. Good afternoon, Chair, Vice Chair, and committee members. I have 27 years of experience caring for children with diabetes who require insulin for life. The administrative time suck into the blender of prior authorizations, reauthorizations, and denials take away critical time from patient care. As a provider member of the aforementioned task force representing the Nurse Practitioner Association of Maryland, we were able to share the frustrations and angst of many patients. A common concern was changing a medication that was previously approved and working because of an insurance requirement. This is scary for a patient or family familiar with how their medication looks and works. Molly, a precocious 6-year-old that didn't understand why her lunchtime blue insulin pen was now green and thinks her school nurse is not using the right medicine for her. Or Isaiah, an underserved teen with OCD and diabetes, both well controlled, suddenly changing. Isaiah's mental health provider explained the restrictions placed on his treatment plan by the insurance company did not allow him to stay on his OCD medication that worked, which then affected his diabetes control. Patients should not be treated as silos. They are rarely a single diagnosis. And the part of the health team that dictates what medicines we can use should not either. We can and should do better for the Mollys and the Isaiahs of Maryland. Our members are providers. They want to provide care, education, and support. Too often, time is spent writing letters, making phone calls, being on hold, or other things to continue a medication that already works. For these and many other reasons, I personally and as a member of the NPAM organization wholeheartedly support HB 932.
Thank you so much.
Thank you. Michael Patty here on behalf of the Maryland Community Health System, a network of 7 federally qualified health centers across the state of Maryland with 55 care sites. We've talked a lot about this bill already. I'll just add that this bill is about transparency, streamlining the process, and to an extent reporting. With that, we support the bill. Thank you.
Next, please. And you can move up. And Sika, you can move up. Go ahead, please.
Good evening, Chair, Vice Chair, and members of this committee. Thank you so much for the opportunity to testify today. My name is Morgan Mills, here today on behalf of NAMI Maryland. We advocate for persons with mental illness and individuals with lived experiences. We are very pleased to be supporting House Bill 932, which helps address patient access issues as it pertains to the utilization review standards in insurance. Navigating the healthcare and insurance system is already difficult, especially for individuals seeking mental health care. The process is very overwhelming already, and additional barriers exist for people with mental illness. The sponsor panel did a really fabulous job explaining this bill. And with that, I will say us too. Just wanted to give a thank you to the bill sponsor and the work group for their efforts. And we urge a favorable report. Thank you.
Thank you very much.
Madam Chair, members of the committee, Ann Seacott on behalf of NCADD Maryland, us too.
Wonderful. Is Daniel Shudock here? Nope. Okay. James Gutman? No. Okay. Yes, 1 second. Why don't we open it up for questions? Just stay seated, please. Are there any questions for these panelists? Seeing none, thank you so much for your time today and all your efforts. Next, we do have a favorable with amendment. And that is Heather Forsyth and Tricia Swanson. Good afternoon. We do have someone online. Will you be so kind and bring them up? Thank you. How are you? And thank you for waiting, both of you. Really appreciate it for your patience.
It's not too difficult to wait in this committee. There's always so much interesting things going on.
Thank you.
For the record, my name is Heather Forsyth. I'm the Deputy Director of the Health Education and Advocacy Unit at the Office of the Attorney General. Among the many services that we offer to consumers is help when they need to appeal the denial of an adverse decision. And those are often related to utilization review. So we're here to offer just a few comments and support, wholehearted support of HB 932. The amendments that we offered, which I outlined in our written testimony, are largely technical. They're friendly amendments. Our support is not contingent on those amendments, and they're really just offered as ways to sort of tweak the language a little bit. I do hope that you'll have time to look at our written testimony. It does include a link to the annual report, and also includes in the testimony itself some of the consumer stories. You've heard some of them today, but I mean, I think the point has probably been made that although the numbers might be small, although 18% in real numbers probably isn't that small, these tend to be very, very painful stories. And so anything that we can do will be of tremendous help. I also do want to echo thanks to all the folks at HGAU. I got to participate in many of the meetings that Dana organized during the interim, and the work and the commitment of the stakeholders and the members of the legislative body in trying to get this thing moving and going was really awesome. In the grand scheme of that word, it was really awesome. So we appreciate that. And we look forward to working with the stakeholders on finalizing this. And we just, echo the request for a favorable report on this bill. Thank you so much.
Thank you so much. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Tricia Swanson here on behalf of Care First. I had written remarks I'm not going to go off of now based on the last panel or the two panels before and the conversation that was had. I want to acknowledge that Care First was engaged throughout the entire process and really likes a lot of the parts of this bill and appreciated the opportunity to work over the last 15 months on this issue because it's an incredibly important issue. We raised a concern about a month ago around the reauth provision, and I can't thank the vice chair and the chair enough for hearing our concerns when we came to the table way late with our concerns, and how much we appreciate both them and MedChi, Ms. Kaufman, for accepting our study language to really more further understand this issue. I would have much rather been on the first panel. I'm sorry that I have to be here on this, but do really appreciate the willingness of the sponsor and the proponents of the bill to do a study to look at this, because we do have concerns that it might be impactful, particularly to Care First members. So with that, again, I do want to thank the vice chair, the chair, Delegate Kerr, and members of this committee for all the work that they have done on this issue, and look forward to continuing this conversation and being helpful in any capacity that I can be.
Thank you. And thank you for, coming to the table, being at the table. It takes a lot to sit there and state the testimony you just stated. And thank you for being fair and acknowledging that, and for coming to the board and supporting the bill with a study language, because it's 15 months. And if we don't do this now, we're going to do it again next year, right? Might as well see how it works, right?
Absolutely. And there is so much good stuff in this bill. I mean, I don't want it to get lost in our concerns around the reauth language. The rest of the pieces of the bill that were highlighted in that first panel, the work that the carriers are going to move towards in making our letters better. I can't tell you how many constituent issues that I hear from all of you on, the letters we send with appeals and grievances. Nobody can understand that. I'm new to healthcare, as a lot of you know, and I found these confusing. And so there's a lot of good parts of this bill that we do really appreciate. And I do really appreciate you all hearing our concern, acknowledging our concern, and putting study language in to really look at it.
Absolutely. And we know we keep our word here, and that is, we're very proud of that. We have Delegate Hutchinson.
Thank you, Madam Chair. Questions for Ms. Swanson?
Yes.
So I see you're favorable with an amendment. I checked to make sure that the amendment was acceptable to the panel and to the bill sponsor. So upon acceptance of the amendment, does Care First support this bill?
Yes.
Thank you.
Any other questions? Seeing none, I want to thank both of you for your time and for being patient and waiting. You're not the last. We have one more virtual, so you can feel good about that. But we do want to thank you as you waited there, and you have waited all day, and we're so extremely grateful to you, okay?
Thank you so much.
Thank you. And the last witness of the day, how are you?
Good.
Good. Thank you for being patient, okay?
No problem.
And we're paying attention to you, so go ahead.
Great. Madam Chair and members of the committee, thanks for allowing me to testify in support of House Bill 932. My name is Margaret Schnitzer, and I've been the director of the Baltimore City Health Department's community asthma programs for the last 11 years. I'm testifying on behalf of the Baltimore City administration in support of this bill, especially as it relates to prior authorization and allowing people who take medication for chronic conditions to continue to use the medication that has worked for them. Our program works with children who have moderate to severe asthma. These children often end up in urgent care centers and hospitals when their asthma cannot be managed and they literally cannot breathe. Our job is to help these children and their families get a better handle on their asthma management. Asthma is a complicated chronic disease that affects about a third of Baltimore City high school students. Successful asthma management relies on using the most effective medication for that child. I've seen firsthand the struggles that families face when asthma meds are changed, especially when they're changed for non-medical reasons. A medication that doesn't work can leave the child gasping for air. Imagine breathing through a coffee stirrer. That's what it's like when you're having an asthma episode. So prescribing asthma meds is both a science and an art. At last count, there are 22 daily meds with at least 7 different delivery mechanisms. Finding the best medication for a child can take lots of trial and error. In addition to which medication to prescribe, medical providers must consider other factors, such as the child's age and their physical capabilities. So, like, can they breathe in deeply and quickly? What's their hand-eye coordination like? Can they hold their breath? This is a determination that should not be made by an insurer. This bill allows children to stay on the medication that works for them. This is the medication that they know how to use and when to use, the one that allows them to play with their friends, go to school, and live a life without being scared that they're going to die from their asthma. I'm sure this is how you would like your kids to live if they had a chronic disease that was being successfully controlled. We are hopeful that you'll vote favorably for House Bill 932. Thank you.
You're welcome. Do you have any questions? Seeing none, I want to thank you for your work. Your work is important and we value it, okay? And thank you for being with us today. And this actually concludes the bill hearing on, did everyone get called? Is there someone that didn't get called today? All right. This concludes the bill hearing on House Bill 932. You have a blessed evening, okay? Thank you for being with us.
Night.
Press down.